Right, if anybody in the room who needs to seat wants to take a seat, that would be great. And anybody outside the room who wants to take a seat? Is everybody in? No, not quite yet? Are we live? Oh, we are. Oh, well, in that case, welcome to everybody. I'll let everyone who's still trickling in to continue to trickle. Welcome to everybody here in person and everybody who's joining us online to our Shift Final Conference. Those of us who have been working on the project are very, very excited to be here today, that we've got this far and that we've been so successful in all of our endeavors, which you will hear about in due course. I have only just learned this morning that I'll be chairing the day, so apologies in advance if it's a little bit clunky, but hopefully everything will be fine. And although I'm giving you the unofficial welcome, I'm going to pass over to my colleague by video, who will give you the official welcome in just a moment. But first, some basic housekeeping. If you're joining us online, obviously feel free to take a break whenever you need. If you have any questions, you can pop them in your chat. Please keep your audio off so that there isn't any interference, but pop the questions in your chat. You can do it in either Dutch or in English, and we will translate it for you. If you are a member of the audience, we had a box that was here, which is no longer here. Oh, it's over here. If you look to the right, to your left, to my right, there's a lovely box that we will throw at you. It's called a catch box. If you do have a question, you must speak into the catch box. So don't put it in your lap and hope that we'll hear you, because we won't. If there's anybody in the audience who only speaks Dutch, this is probably not going to be helpful because I'm going to say it in English, but do try to sit next to a Dutch English speaker so that they can translate anything that you need. Actually, Wim, do you want to translate that in Dutch because it maybe makes more sense? Brilliant, thanks, Wim. A little more housekeeping. If there's a fire, the doors are there. If you need the loo, they're to the left and at the very back. And I think that is everything that I need to say. We do have a slide that's coming up in a moment with the agenda on it, and I will talk you through that. We can't see it very well, so please scan your little lanyards. We did that in person deliberately to make sure that everybody in person at the conference actually uses their little scan things, because we worked really hard on these. Without further ado, I shall pass to my colleague on video.
Good morning and welcome to everyone. Thank you for attending this final conference of the Shift Sexual Health in the Over 45s project. In this introduction, I want to answer the following questions. Who, what, and why, as a brief background and introduction to the project. To start with the who, we are the Shift project, funded by the Interreg 2Cs programme. When I say we, there are 11 partner organisations from the UK, France, Belgium, and the Netherlands, from a range of sectors, including local government, healthcare providers, universities for evaluation, and sector-specific not-for-profit organisations and charities. My name is Alice Chapman-Hatchett, and I'm the Director of the Health and Europe Centre, the lead partner for the Shift project. Our role in Shift has been to build the project consortium, put the application together, and then deliver and manage the project once it was approved for funding. Moving on to the what and the why, what did we do and why did we do it? Previous work in this area had led to a realisation that there was a correlation between a gap in sexual health services and a rise in sexually transmitted infections in the over 45s age group in the 2Cs area, and that socioeconomically disadvantaged groups, including the homeless, migrants, sex workers, and non-native language speakers, were at greater risk than others. The World Health Organization's report on the social determinants of sexual and reproductive health is clear that these groups are underserved by services and that their needs are not being met. There is also still a lot of stigma around the subject in this age group. Sexual health service providers still tend to focus mainly on younger age groups. And with an ageing population, this focus needs to change. So what did SHIFT do? We have co-created and piloted a model for future service provision to improve sexual health amongst the over 45s, including techniques for engaging hard-to-reach groups. We have then adapted this model to reach socioeconomically disadvantaged groups, taking into account cultural and subject sensitivity, and creating this as a multilingual model. Finally, we have jointly produced and piloted a training programme based on extensive engagement with healthcare professionals, implemented via existing services. At this point, I'm going to hand over to colleagues to introduce our first keynote speaker, further setting the scene for SHIFT. Thank you.
Thank you, Alice. It does feel strange to be thanking someone who's not actually in the room, but here we are. I should have said before, my name is Amanda Dawes, and I am a health and equalities consultant working on behalf today of Metro Charity, one of the project partners. I'm going to invite my colleague, Dr. Ian Tyndall, up, who's going to give a background and introduce our next keynote speaker.
Good morning, everyone. I'm delighted to welcome our first keynote speaker, who is Dr. Sharon Hinchcliffe. Sharon is a reader in psychology and health in the Department of Nursing and Midwifery at the University of Sheffield. I think Sharon is a real powerhouse in sexual health research in the older age. I think she's one of the leading people in Europe, and we've come across her many times over the last few years in our various evaluation efforts with the project. And I'm just amazed at how many times Sharon comes up and in what kind of context. For example, she's just published a book on addressing sexual rights in the older age with her colleague Catherine Barrett, and that's really aimed and tailored at health and social care services that Alice mentioned earlier, and trying to give them the information that they need to support people in the care homes and to ensure that they have rights, that their clients have rights in the older age and they're not forgotten about. So I think that's really important book. She's also published in many of the top journals in our field, such as Journal of Sex Research, Age and Aging, Culture, Health and Sexuality. So she taps into many of the key themes that we're going to be discussing here today in our final conference. She's also does some really interesting creative work. For example, she works with an artist, Pete McKee in Sheffield, where they're using art and humour to try and raise awareness of intimacy in older adults. So it's not all just about sexually transmitted infections and things that might go wrong and looking after needs, but also our emotional needs as well. I think that's really important, and I hope that will come through in our many talks and sessions today as well. Sharon is a big believer in sexual rights, and that she has she's probably the leader of the Sexual Rights Charter. For some people might be aware of. I'm sure she'll mention some of that in her speech today. So I'm delighted on behalf of us as University of Chichester Evaluation, but all of the partners in the project, to welcome Dr. Sharon Hinchcliffe today. Thank you.
Thank you. I'm attached. Good morning. How are you all today? Good? Yeah. Thank you. I'm really pleased to be able to talk about a topic that's really close to my heart, the sexual rights of older adults and how that connects with healthy aging, but also to celebrate the SHIFT project with you as well. It's been one of the most amazing projects to actually watch evolve and to culminate in this final conference, and the outputs are absolutely fantastic. Did you know that around 100 years ago, medics were advising individuals that wanted to get pregnant, any married couples, that they should be having a simultaneous orgasm, and that way they would be having an offspring that was superior? No? And perhaps more recently, about 10 years ago, we had gerontologists that were advising us to have orgasms about 3 times a week if we wanted to have fewer wrinkles around the eyes. There's no need for Botox then, is there really? So that is one of the things about sex that fascinates me, is that there's been some weird and wonderful sort of things that are attached to it. But seriously, I think one of the important messages to take from that is that the meaning of sex and how we understand sex does change over time and place. And that is certainly something that I want you to bear in mind while I'm doing my talk this morning, but perhaps for the whole of the day as well. So sexual rights, they are human rights as applied to sexuality. And quite simply, they exist to protect us from discrimination and prejudice, to make sure that we're treated with dignity and respect, so that we can attain the highest levels of health and well-being. But we're understanding sexuality here as both a practice and an identity. So I want to take you back to the 1990s, if anyone's old enough to remember the 1990s. Well, that's when sexual rights began to emerge as a global discourse, and we saw it in the reports from the United Nations, but also in the reports from the NGOs such as the International Planned Parenthood Federation and the World Association for Sexual Health. But there's no doubt that the cultural climate had a part to play in this visibility. For example, the key social movements, feminism and lesbian and gay rights, were maturing around that time. And of course, we were 10 plus years into the AIDS, HIV pandemic. But despite that, sexual rights have been around for quite some time now, but they have been predominantly applied in relation to younger people. I think one of the reasons for this neglect relates to what Shirin Hederi is acknowledging here in this quotation, that sexuality is subject to power relations in the personal and professional domains, and always, always politically motivated. If we think about the sexual health agendas of governments back in the 1990s and to an extent today, then the priority areas were around preventing STIs, preventing HIV, and preventing unintended pregnancies. And because these were issues that largely affected younger people, then older adults were excluded. There has been a little bit of literature around the sexual rights of older adults since then, but that has been in the minority, and it has been predominantly aimed at people who are living and working in care homes. So saying that to breach their sexuality, to not let people have sexual relationships, is a human rights issue. But I also think that this neglect relates to the social position of older adults in society. Quite simply, they're getting older and ageing is associated with decline, disease, and becoming dependent on people for care. And we also have a sexless older age stereotype where we are expected to sexually retire or sexually decline. Now, this is really important in that it does intersect with other items of our identity. For example, gender, and I'm going to give you an example now that comes up a lot in my work, and the assumption that as women get older, as they get to the menopause, they lose sexual desire and become sexual undesirable as well. Now, that is something that does come up a lot. And interestingly, this is not just something that affects the high-income countries. We find evidence of this in low and middle-income countries as well. And for one example, there is a community in Africa where they believe that if a woman post-menopausal has sex, then that brings poor health, possibly death to herself and to her partner, and then there's no entry into the afterlife because that's prevented by the ancestors. So that is a belief, a traditional belief that is still evident to today. If you're thinking that this sounds like ageism, then I think you would be right. I certainly think that that's what's going on here. We're talking about ageism. And even though we've known for quite some time that older adults are sexually active and that they have diverse sexual lifestyles, sexual rights have not been deemed important in our research, in our practice, and in our policy, even though there's a lot of research in this area now. There's a lot of research on the sex lives of older adults, but sexual rights tends not to be considered. So, I think as well this silence is dangerous. Exclusion perpetuates myths and misinformation, and quite simply, when there's the silence around the area, we've got no comparison point. This is something that I find in my research quite a lot, because I talk to people, I do qualitative research, I do interviews with individuals, but I do a lot of public events as well, and people come and talk to me at the end, and they quite simply ask me, what's it like for other people? Is this normal? They don't know about the sex lives of other older adults, so they don't know if what they're going through is quite normal. So I think that in itself is discriminatory. It really is. It's a problem that we need to address. But I think it does a disservice to older adults as well. You know, many of today's older adults are the ones that brought around social change that benefits us today. And I think that's most powerfully demonstrated in that image here of Gloria Steinem. So how do sexual rights relate to healthy ageing? I think first, we know that sexual activity has been proven to have benefits for health and well-being. I've got some examples on the slide. There's decreased sensitivity to pain, lower levels of depression, higher levels of relaxation, and because of that, individuals report better sleep. There's a reduced risk of urinary incontinence, better cardiovascular health, and reduced risk of getting prostate cancer. Okay, but the next one's my favourite. Are you ready for it? As apparently as well as a nasal decongestant spray. So, I mean, yeah, it's quite funny, isn't it? But you know what to do if you've got a cold. But we do know that higher levels of sexual activity are linked with better quality of life and well-being, and even being better able to cope with chronic disease. And I think considering the levels that we're seeing of chronic diseases in our older population and that we're living longer lives, but we're living longer years in poor health, then this is a really important point to be aware of. I think sexual rights relate to healthy ageing in another way as well. So secondly, they protect us from discrimination. We know that discrimination in any shape or form is dangerous. We know that it can have an impact on our health and well-being, and especially if this is happening on a consistent level. So how does that manifest when it comes to older adults and sexuality? Well, I've got some examples on the slide again. Older adults tend to be excluded from health campaigns. And indeed, if you Google sexual health campaign and look at images, all the images will either be on young people or they'll be in a fashion that is directed towards the younger generation. They won't be presented in a way that older adults can identify with. Something that comes up a lot in my research as well, and I think just because I work in the sort of nursing and midwifery field, is that older adults are not always informed about the sexual side effects of drugs. And as we know, we get older, we're more sensitive to the effects of drugs overall, so this is a real serious issue. And I have had GPs say to me that they don't tell older adults, but they do tell their younger patients as well. Not being offered a treatment or a service. I've had participants tell me that they've requested an STI screen and been told, no, what, you don't need one. There's examples of having privacy unnecessarily invaded as well, and this is a real issue for individuals if they need any kind of personal health care, if they need someone to come into the home, or if they need to go into a home and they're not actually out to anyone other than their family, if they're in the same-sex relationships or transgender, but they're not actually publicly out. And then the last one is being dismissed when an individual raises a concern with a health or social care practitioner. And I've got an example on the slide that I'll just give you a few seconds to read. So this is a real lived experience, and at first view, you might not think it's an act of discrimination. However, when you consider that Relate is a service that offers counselling to couples that are having relationship problems, then this is not appropriate. This woman thought her sexual desire loss was physiological, and she was trying to get help for that. And when you look that she's in the age bracket of menopause, then there's a good chance it's something related to that. So this is discrimination that's kind of hidden. There's also fear of discrimination as well. Again, another lived experience from a participant. I'll just let you read that. So this guy in his 60s is healthy and well. is in a happy relationship with his spouse. They're both extremely distressed by the fact that he's got erectile dysfunction, but his fear of being judged for showing an interest in sex at his age prevents him from getting help for that problem. Now, this exact quote, I remember sitting and interviewing this guy. It is some years ago now, but he is the point. This is one of the examples that really drives me on in this area to try and make a difference. And I think that impact can be brought into sharp focus when we think about why people seek help for a sexual issue. So this is some of the results from a study we conducted with partners in Norway, Denmark, Belgium and Portugal. You can see that the main reason for older adults to seek help is that sex is important to me. It's quite an interesting gender difference there, isn't there? The men are the blue, the women are in orange. And the next reason was that sex is important to our relationship. And you can see there's more of a gender balance there. I think as well, this brings it all home when we look at the treatment-seeking pathway. I don't know how well you can see this because it's quite a big diagram on a small screen, but this is data that we collected from NATSIL, which is the National Survey of Sexual Attitudes and Lifestyles in the UK. We looked at their quality. I wasn't part of the team, but I did help them analyse their qualitative data, and we looked at individuals who reported experiencing a sexual issue in the previous 12 months, which they thought was caused by a health condition or a medication, and then we analysed that data and came up with this pathway. Hopefully these slides will be shared and you'll be able to have a good look at that. But what's happening, we've got the thick grey line that goes through the centre. That is the actual pathway. We start with awareness of a sexual difficulty. We've got the big sort of square in the middle saying seek professional help, and then the reaction of the doctor, whether the doctor's supportive and listens or is dismissive. But the bit I want to focus on is the first bits between the awareness of sexual difficulty and seeking sexual help. There are so many stepping off points. It takes a lot of time to sort of decide whether or not to seek professional help. People wait to see if the problem goes away on its own. Even with STI symptoms, people delay seeking help. They might try alternative fixes. I'll stop drinking, I'll stop smoking, maybe I'll lose a bit of weight, maybe that will help. And then if that doesn't work, they're back on the pathway, the thick grey line going through the middle. They might talk to their partner, but they might not, because sex within a relationship is quite a sensitive subject, and there's all sorts of emotions that come into play here. So given that this is such a complex situation, whether or not people decide to seek help, then the implications can be serious if an individual is indeed dismissed. And again, I've got another lived experience from one of our participants there. So again, we've got a guy in his 60s who's relatively healthy. He's in a relationship with his partner. It's a strong relationship, but their sex life has come to an end because they were dismissed by the doctor. It might not seem like discrimination. You know, the doctor's gone, oh, maybe you're going to be all right taking Viagra. However, when the topic is sensitive, when we've plucked up courage to seek help, then things like this can be devastating because we're psychologically more attuned to the negative responses. Yeah. And this guy was taking all sorts of other medications, so he was worried about the interaction of Viagra with that. And that he just wanted a yes or a no answer. Didn't get one. Sex life has gone down the pan. Okay. So I focused on some examples which demonstrate what happens when a sexual rights approach isn't taken, or when the sexuality of older adults isn't really taken seriously. So now I want to look at what can happen when it is. I think, you know, this is about inclusivity, this is about visibility, and this is about removing any stigma that's associated with sex in our later years. And I think by doing so, we will have better health and relationships, we will have better relationship satisfaction, and indeed the connectedness, which is so important to our health and well-being, will be supported as well. I've been reading this morning that apparently if we have that good relationship with a partner, that can increase our life expectancy. I've got another example here. This is an example of good practice. It's a real experience from one of our participants. So this is being proactive. And I've just realised nearly all my comments, all my quotations are about erectile dysfunction. And I've got another example here. This is about being reassured. And again, an example of good practice. So despite there being examples where our sexual rights are breached, I think there are examples where sexual rights are supported, but these do seem to be in the minority. I do hear more about the negatives and more about the bad examples than I hear about the positives, which is quite sad, but I hope that that is starting to change. And I think it is. I think there's a lot to celebrate. I've put some examples on the slide now that shows that the actual landscape is changing. It is improving. And I couldn't have stood here 15, 20 years ago and said this. So what we've got here, we've got various different examples where colleagues and academics, clinicians have come together, they've conducted their research, they've used the evidence base to develop interventions to drive change within services and within society. There's some various examples on there, and this, I must say, is a really positive way forward. But I want to end by saying we can all make a difference. I think that's a really important point. If we remember to consider the sexual rights work within the work that we do, so our research, our education, our practice, and our policy making. We need as well, I'd encourage you to remember that we've all bring a life history and a sexual history to the table. And I think for older adults, then it might be a little bit not more unique, but we might need to consider more influences within that, for example, because if we are older and we've lived through a time where to be in a gay relationship is deemed a mental health problem, or whether it's something that's punishable by death, or even as a woman in a heterosexual relationship. And I've spoke to quite a few that have been in a relationship and have married at a time when male sexual pleasure has been prioritised. So they've never really enjoyed sexual pleasure themselves until they've got older, until they've got into their 70s, until they've been divorced or widowed. And finally, I think if we truly want to be inclusive, then if we include older adults from the outset in the work that we do and bring a diverse range of voices to the work that we do, and then we know we can be truly inclusive. So I think that is me for now. Thank you all for listening, and do ask me any questions. I think I'm taking questions on the stage, but I'm around all day as well if anybody wants to ask me anything else. Thank you. Do we take questions from the floor first? And then the iPad? There's nothing here yet. Has anybody got anything they want to ask?
Okay. The examples you were given are about men. Is that just by coincidence, or?
I think it is just by coincidence, isn't it? I hadn't realised, and I put more men on than women on the slide. But you do get a lot of men taking part in this research, and I think erectile dysfunction is what they want to talk about, so I think that explains why we get that. Although women do experience sexual difficulties, we know, as we get older. These tend to be around sort of menopausal age and might be related to sort of vaginal dryness and pain on intercourse and things like that. But it's interesting with the men. We saw the difference in terms of why they sought help for sexual difficulties. It was more important to me. We do find sort of discrepancies between men and women within the data sets, and I don't know if it's anything that you've found in SHIFT, and even with the heterosexual sort of individuals, that we're finding that there's more men that are reporting sexual activity than women, so higher levels of sexual activity, and we think there's something going on there about social desirability, and for example, older women have grown up in a time when we were expected to not sort of admit to enjoying sex, and to be quite chaste about that.
Yeah, I think we'll talk a little bit more about it later, but we found when we were doing outreach that a lot of the time when heterosexual couples came to the table, it was to discuss the female partner's lack of libido, but it was brought up by the male partner. Very interesting. But my question was, I really liked at the end that you gave the examples about sort of good practice and what was reassuring. I guess my question then is a follow-on around what would a good outcome be? So if somebody's, reassured that it's very normal, and they're potentially given a drug or something to, what would a good outcome look like? How do we know that we've sort of been successful with older people?
Yeah.
I guess is a question.
I think that's a good question, yeah. And I think from just my research and outreach work, I think often older adults just want to be able to have that conversation. They want the topic to be a legitimate one to have with practitioners, health professionals. So sometimes just that in itself is enough. Of course, there's the prescribing the medications if that's needed, but also I think referring to these resources that are building up now over the years, I think that's a really important part as well. But from my perspective, it's removing the stigma and removing the ageism as well. Because like I say, I've been working in this area for 20 years now. And even though I'm seeing differences in society, there's more acceptability about the sexual agency of older men and women. Within services, we're kind of really, really lagging behind. There's a real, so I would say if you could push your outputs within services and get them out there, I think that's the support that individuals will need, and benefit them. Yes. Do you need the box?
We'll get our footsteps up for the day.
Thank you. I've never held a box before. Question is, obviously you've got the Sexual Rights Charter.
Yes.
And it has been publicised. How do we make that more public? And how do we make that public not just for health professionals, but wider communities and for everyone to be able to talk, rather than, as you say, perhaps leading it just from the kind of clinical side?
Yes. Okay, thank you. So we did launch, and I didn't say much about it, but we launched a Sexual Rights Charter for older adults earlier this year, and that was based on the research evidence that I've shown some of it to you today, but also some engagement work with older adults as well to make sure this was a charter that actually spoke to older adults and their diverse kind of experiences. So that is available online, so anybody can access that. We're just asking for people to sort of get in touch and have a conversation before we let the materials go. Because the aim of the Charter is to make sure that we're having conversations about a topic that's quite stigmatised and quite taboo. And what we want to do, we just kind of want to normalise it, if you like, so that sexual activity and intimacy is seen as part of the normal life course and normal health and well-being, as it is for many other individuals, and especially the younger age group. So that charter has been designed so that it's deliberately broad and it's being picked up by communities. Reading groups are using it. We've got debates and we've got art groups thinking about using it. But also within local councils as well, who are developing policies for older adults about sex and relationships. So I'm really pleased that in just the few months that that's been launched, it seems to be making a difference. If anybody wants to hear more about it, just hit me up. Okay, I've got a question on the tablet. Oh gosh, it's whether or not the recording's available, but that's... Yes. I'm sure it will be. Yes, it will.
I'm trying to say it correctly, but in your research, did you also research about the cultural dilemmas? So aging and sexuality is one thing itself, but also the cultural dilemmas makes it more difficult. Can you say something about that?
Yes. I think certainly, yeah. There are certain communities where it is even more of a taboo topic to talk about, and that's for sure. So I guess we have predominantly done our research in Europe, and we've done some research in Australia as well. And interestingly, despite these sort of geographical spread and sort of differences in time, we do find the same things that keep coming up over and over again. And that is that individuals might kind of want help, that sex is important to them, Not always. Some people are quite happy to not be sexually active as they, as they get older, or maybe when they're younger, and that's one of the sexual rights, the right not to be sexually active. And I'm saying that because there's some individuals that really push this sort of agenda that you need to be sexually active to age well. So we do find the similarities across cultures in terms of sexual health and well-being and the place and meaning of sex within our lives. But I think there's some communities that are underrepresented in research, and that is where we need to sort of direct our attention to now. Yeah, in terms of culture, but in terms of gender identity as well, and making sure that we are being truly inclusive, because the evidence base is huge when it comes to white and when it comes to straight individuals. We really need to make a conceited, what's the word? We need to make an effort to be more inclusive in the research that we do. Anyone? Do you want the box? I ought to have it, didn't I? I could have thrown it to you from here.
Hello. So I just wondered, was there any country or jurisdiction or service from your research that you think's got this right, and what are those areas? What could we learn from those places doing it right?
Oh, that's a tough question. Oh, gosh. It depends on what area we're talking about, I think. I think if we're talking about exploring diversity in terms of sexual orientation and gender diversity and care home research, I think Australia is doing a fantastic job in the work that they do there. Yeah, and I think from my own experience, which is quite limited, I haven't been all over the world. I've worked with some brilliant partners in various different parts of the world. But the work that we have done is kind of highlighted the same things. So I don't know if there's any specific areas of best practice as yet, or the best practice. Yeah. But I know that's going to change with the shift outputs. That is our future, isn't it? They're so good. They really can make a difference. Oh, so I've got a question. Yep, I'll read it out. What do you think about the fact that sex is more available now, such as within the porn industry? Does this have an effect on the age range as well? So that's a really interesting question. And one of my colleagues, Mervyn Eastman, just recently published something called a provocation paper about sex and intimacy, and that was published with the Royal College of Nursing. So I can, if you can't find that, I can share the link with you. And he's got a little section in there about pornography and older age and how we can be restricted from being able to view pornography if we go into a care home and have that kind of liberty taken away from us. So in terms of the porn industry, I think, well, yeah, sex is more accessible, isn't it? It's a different type of sex that was accessible to when I was growing up, never mind people that are older than me. And I don't know if that's quite having a difference in terms of how people engage with it. I'm not sure if there's been any research that's done with older adults and porn use yet. Oh, and another area that needs exploration is the use of sex toys in older adults, because there's very little research that's been done there as well. So if anybody wants to sort of research that as a topic, then, please do. So I've got a question here. How come it is such a topic since we've grown up in the 70s and 80s? I remember how common it was to sunbathe topless and how easy relations were switched. Or is this just my perspective? I think that's quite an interesting point, isn't it? And it talks back to what I was saying at the beginning about our ideas about sexuality and what is sexual agency and expression can change over time and over place. Certainly, I remember growing up in the 70s and people used to sunbathe topless in the garden and they used to use baby oil. Does anybody else remember that? So I think our ideas about what is kind of normal sex do change over time. But I think the biggest thing for me here is the ageism, that we're really struggling to shift that. And that is one of the biggest barriers, I think, to progress work in this area, in our services in particular, because it is not being prioritised. I think I mentioned that in one of my slides. The services have been set up for younger people, so to try and adopt them and to be more inclusive to our older generation, then, I think we've got some work to do there. Is my time up? Have I just seen somebody say, oh? Yeah, is that my time up? Okay. Thank you, everybody.
Thank you. Am I on? Yeah, now I'm on. Thank you. That was absolutely brilliant. And hopefully you guys all found it as interesting as I did. And I'm really pleased to see that those of you who are online are engaging. Really great questions coming through the chat. We now have one more little session before our break. And I should have said earlier that our breaks are going to be from 11:10 until 11:40. And then a lunch break from 12:45 until 1:45, because everybody I know always likes to plan their day accordingly. So I'm very pleased now to be able to welcome two of my dearest colleagues, Dr. Man-Yi Tung and Stephen Grice, who are going to talk about SHIFT in general, our model, our website, and a number of other things. So please give them a warm welcome. You don't need this.
Thank you very much, and good morning, everybody. And thank you very much for being here in person to attend our SHIFT conference, and thank you very much for those of you online at home or at office who are interested in what we have to say. So my name is Man-Yi Tung. I'm a sexual health consultant working for Kent Community Health Trust.
And I'm Stephen Grice, and I work for Kent Community Health Sexual Health Services.
And what we're here to do is really talk to you about why we developed SHIFT. Why have we been here? What it is and what it means, not just for us as the SHIFT partners, but for anybody else who may be engaging with or working with people aged 45 and over, or perhaps you, like myself, I'm 49, maybe in that age group. And how do we move forward with what we wanted in terms of sexual well-being, sexual health, and as Dr. Hinchliffe just said earlier, sexual rights. So just to give you a summary, and I know Alice did talk about this earlier, the SHIFT project is an Interreg EU-funded project, of which €3 million were allocated to this project. And as we've been told, we've had 11 partners from 4 countries. And it's been 4 years and a COVID pandemic in its inception. But the ultimate goal was to bring together health and academic professionals along with the community, because without co-design, projects like this don't last. We need to involve the community, we need to involve people, and we really basically want to improve sexual health and sexual well-being. So Stephen, you're going to ask me a question?
Forgot my lines there. So, Man-Yi, can you tell us a little bit more about SHIFT?
Brilliant. So, just
I'll get the easy bits.
Absolutely. Just to say that it is a project aimed to improve the health and sexual well-being of the over 45s. But as we've discussed earlier, a lot of health promotion is based around certain risk groups, but doesn't include a majority. So a lot of it is around young people, LGBTQ+, and potentially pregnant women. These people will receive public health promotion around sexual health and well-being. But what about the rest? So, Stephen, I'm going to ask you, why are we doing SHIFT?
I think rightly, as you said, when we look around, the rest of the world, not just the UK or Europe, lots of public health campaigns are targeted to young people. They're targeted to certain demographics, rightly so, because that's sometimes where the greatest burden of sexually transmitted infections are. However, what we don't get to see is other people. There is no accurate representation and there's no voice of older people within these demographics. Certainly when you look at poster campaigns or online campaigns, you don't see me. I am at the right age. But certainly they don't see some of the rest of us. You see those young faces peering out to you, and actually you don't take away those take-home messages, with regards to getting tested, safer sex, because actually it doesn't represent you visually. You can see from here, some of the campaigns that we've taken, or some of the newspaper headlines that we've taken from the UK, they're very salacious. It's all a bit of tongue-in-cheek, a bit of fun, Randy Derbyshire pensioners. It's not positive. It's not that take-home message that we want to see, for older people. You know, we all have that right to have a sexual health and well-being lifestyle, you know, at any stage of our life. But we're kind of prevented from doing that because it doesn't target us, it doesn't look like us.
So, as you said, Stephen, a lot of the imagery, newspaper headlines we have are really negative. The language we use is not inclusive. Yeah. The imagery we use is not kind of diverse enough. But if I show you the next slide, what do you think?
So this next slide, you know, is really good. Again, okay, there's no image to it, but actually we're focusing more on the language, and the language actually appeals to everybody. It doesn't stigmatize, it doesn't segregate, it's appealing for all. You know, and it's a really important message with World AIDS Day, you know, tomorrow. You know, you equals you. If you're undetectable, you're unable to pass it on. You know, so we need to be looking at more, I suppose, less visual, or maybe more visual, but actually having that right visual there that actually appeals to that demographic so that we're looking at properly, you know, what target market are we looking at to improve people's sexual health? And then can you tell us a bit more, you know, you said earlier about having 11 partners. What did that look like during the project?
So as we've said, you've seen Shift. You're all here, those of you who are in the audience, and for those of you at home, hopefully you'll have had access to our website and things, and you'll have had an idea of what Shift is. But what have we been working on as 11 partners is 3 work streams. I'm going to concentrate on what we call Work Package 1 or Work Stream 1, which looks at the overall model for the whole population aged over 45. Later on, colleagues will tell us a little bit more about engaging with more vulnerable and people who may have difficulty accessing services. And then finally, we'll also hear from colleagues who have developed an educational training package, which would be useful for lots of different people, whether you work in health or whether you are allied to health. But if you engage with populations that are aged over 45 and over, these educational tools will help you open up the conversations, which, as we saw in the earlier presentation, sometimes just don't happen at all. So if we can start that dialogue, that's where we want to go. And in terms of who's delivering Shift, apart from ourselves as clinical partners, we work for the NHS. There are public health partners who are really interested in the wider population health, not just, as we said, young people or perhaps certain groups like LGBT or pregnant people, but the whole population. We've also got the community involved in this co-design, and we've got academic partners and our university colleagues who are really there to support us to build this model. And this model, the Shift model, is basically to empower someone to think about their sexual health. They don't have to do anything about it, just think about it. And once you think about it, it's what you do, whether you choose to take action or whether you choose to be saying, I'm okay, I'm happy where I am. And that's what our Shift well-being and health model is.
So you mentioned about, obviously, co-design. How did that model come about, and what does it look like?
So, at the beginning of the Shift project, there was a lot of debate of how do we get the community involved? What do we need to know about what people want? So at the beginning of the project, there was quantitative surveys done, there were focus groups done. We actually spoke to the community, got them into us, either through online surveys or focus groups in UK and European partner countries. And then 4 key themes come out, and hopefully throughout all the presentations that you're going to see today, and hopefully through looking at our website, you're going to see us looking at these 4 key themes. Improving people's knowledge. What do they need to know about their own body? What do they need to know about growing older? We want to improve awareness about sexual health. Why is it important to me? I'm 49, you may be 55, there may be somebody who's 85. Why is it important to them? Access, if people need services, a bit like some of the case studies we saw earlier. Why do we need to improve access? How do we help people to improve access? And finally, the big one, stigma. We've already said, and we've seen from some of the headlines that you were showing earlier, some of them are very salacious, some of them are very not positive. How do we change stigma? How do we support that? And we hope Shift will be able to do that.
So what does it look like now? Show me your pretty picture and model that you've got.
Okay, I can show you a pretty picture and a model. First of all, the shift is a whole thing. It's not just one part, it's multiple parts, multiple facets, and I think that's really important to think about it. There is something called behavioural change, and I'll show you a pretty model shortly. That is what we want you, as either a person over 45 or a person consulting with a person over 45, to think about. But to support the delivery of this model, there is a website, hopefully with inclusive pictures, inclusive language, lots of broad topics. Also, there are going to be some films that we've produced, and I'll go through those a little bit later. And then, as I said, work package 3, educational tools. How do I help open those discussions if I'm a practitioner or I work with the community? How do I do that? And then also we talked about how do we access hard to access or vulnerable groups. So here comes the pretty picture.
It is, and it's very nice.
There we go. This is COM-B. And fantastic academic colleagues have helped bring this together as a diagram of how someone's journey through shift will be. So if you put yourself, or I put myself in the middle of the diagram, I'm the blue person. On the outside, the purple parts are the activities that shift want to deliver to help engage those 45 populations. So we've got the website, we've got films, poster campaigns, newspaper articles, radio, anything that gets everyone talking. Anything on anybody's website, if anyone wants to put a link on their website to the Shift website, please go ahead. Then hopefully people, the community, start to see things, and then it moves into the blue, which is, does it help reduce stigma? Does it help improve knowledge? Does it help improve access? Does it help improve awareness? All those 4 things that Shift wanted to change. And then it comes to the yellow, which is closer to me or closer to the individual. What am I going to do next? What action do I take? How do I do this? Or actually, yeah, I'm perimenopausal. Yeah, I might experience this. I'll go and look at the Shift website on perimenopause. Don't need to do anything. But it's given me or other people the chance to have a look. And I have to say also, apart from English, we also have a Dutch version. So anyone who's a Dutch speaker, feel free to have a look at our Dutch version as well. And as I mentioned, there is the website.
There is the website. The website, please go on, have a look. It's got some really good information on there. The images are very appropriate. And hopefully, like you were saying earlier, you know, it helps people to start that conversation. You know, like you say, you don't need to have to do anything about it, but at least you know it's there so that you can look at it, you know, and realise that what may be happening to you or whatever you're doing with your sexual intimacy or trying to enjoy it, that information is there for you to be able to access, you know, and do as with you what you wish.
Absolutely, and there's lots of different pages on there, so please have a look, including, can I have sex after a heart attack? And that's unfortunately a common medical ill health for a lot of people, men and women, as they get older, and people start wondering, can I? The answer is yes, you can.
Yep.
But there's a little bit of a time wait, but not too long. And I talked about the Shift films. Out in the lobby, there's an iPad, which has the Shift films available. They're in English and in Dutch. Please feel free to look at those. And they basically include examples of lived experience and how we can change that, and also examples of how we can reduce misinformation, how we can support positivity in people wanting to have sex, sexual health, sexual well-being discussions from that. So if you're at home, please log on to the Shift website and you will find links to the films there. So Stephen, as we come to the close for the last couple of slides, why do we actually need Shift?
I think, as we've heard from a previous speaker, and if you look at the data, certainly in the UK, much, again, and I don't want to malign certain demographics, but much is geared towards younger people. You know, when we look at STI data in the UK, we're very good at capturing that data, but actually what we tend to focus on is younger people and, you know, how do we reduce that burden of infections in that younger age group? When in actual fact, if we look further back in the data, you can see an increase in sexual infections in older people, and it's slowly rising, but nothing is focused on that area. And I think that's a really important thing for Shift to look at, so that people are aware that where they can get tested if they want to, or, you know, just have that information to realise that actually it could be an issue for them.
And I think linking into what Dr. Hinchliffe said earlier about an older person requesting an STI test and being refused. Yeah. Yes, the numbers are small, and you can see on the screen there's an example of certain numbers there, but the numbers will increase. They won't be, as you rightly say, as significant as younger people, but these numbers are going up, and therefore we need to include this population in those discussions and help them access what they need.
Definitely, it's not a reason to ignore, you know, it's a reason for us to work a bit harder in order to open up those conversations, you know, to be inclusive so that we don't have that silent majority.
And lastly, Stephen, just summarise to us about kind of sexual health and well-being and what the SHIFT project really wants to achieve, and hopefully the audience will help us achieve.
I think for me, SHIFT has been really about opening up those conversations. It's about giving people that opportunity to ask those questions. You know, it's about us as healthcare professionals and the wider workforce, you know, looking at, you know, how do we give those people that opportunity to be able to, you know, express about their sexual intimacy or desires, you know, because for so long, you know, we've already mentioned stigma. You know, Sharon had some really good slides with regards to when they've approached healthcare professionals, the negative responses that they've got. And it's about how we communicate people and empower them, you know, being really inclusive, focusing on that positive language, because also often, as we've shown, you know, in one of the slides, it's not positive language when it comes to older people. You know, if we ask our kids, or if we've got kids about our parents having sex, you know, straight away it's the ick factor, isn't it? You know, actually, and it shouldn't be like that, because we're all entitled at any stage of our life to you know, to have the sexual health and well-being lifestyle that we want to have. You know, and that's, for me, the take-home message for SHIFT is we open that up, we give people that opportunity to be able to, the information to look at online or wherever, so that they can then start making those choices.
Brilliant, thank you, Stephen. And from us and all the SHIFT partners, we really want to say we want to keep this conversation open, we want to expand this conversation, we want everyone to be able to join in, regardless of gender, sexuality, relationship status, but certainly say that we should be having that sex discussion, whether it's about intimacy, whether it's about the actual sex act, whether it's about STIs, whatever it's about, growing older and being able to have the sexual health and well-being that we enjoy.
Yeah, definitely.
So thank you very much for listening. I just want to say we hopefully have access to word cloud. So what we want you to do is, if you can scan our QR code, or if you go to menti.com and enter the 8-digit code that you can see at the bottom of the screen, there will be a question for you. And from this question, we want you to put in a single word, or if you're very clever, you can put 2 or 3 words together, but it still has to be a single word, answer of what you think SHIFT is about. So that's the first question, and we believe this word cloud should be open up until about the lunchtime break. And then it will reopen after lunchtime, and we will ask a second question. And then hopefully at the end of the conference, we're going to show side by side what everyone thinks now about SHIFT and what everyone thinks towards the end of the conference about SHIFT. And if we can start that tide of changing things, if we can start that tide of moving that conversation forward.
I'm looking forward to what it's going to look like at the end.
As you say, look at this already.
I know.
Inclusiveness, fantastic. Normalisation, inclusive care. So as you say, this is what we're thinking now. It'll stay up until lunchtime. And then this afternoon we'll ask a second question, and we'll see side by side. And those of you at home, please do log in as well. Give us what your thoughts are and help us keep this conversation going. Thank you very much for your time.
Thank you.
Don't know. Questions at all?
I think we've got time.
Some
Am I on?
questions.
We've got time.
Yeah, I think we've got time for some questions from Dr. Monnier and Stephen, if anybody has any. I'll stay up here just in case they don't. But we have the lovely catch box, and obviously if you're joining us online, please do pop into the chat questions here. I can monitor it from here if that's easier. Somebody must have a question. If for nothing else than about the amazing presentation style, I loved it.
Thank you.
And just so we're clear, by the way, my mom and dad, I believe, are watching her today. Everybody is allowed to have sex over the age of 45, except for you two.
It's true, though.
Which is not what I'm supposed to say, but that's what I'm saying. Right, any questions? Tom, here, you want to grab the, you've got to get the catch box over there.
I'm interested, I noticed one of the words that popped up briefly when we saw the word cloud was bridging. And I'm interested in this bit. We talked a lot when we started the project about where we started the lower end of the age bracket. And what I'm interested in, how we bridge things so that we don't just have the conversations coming up potentially later on, whether it's at menopause, whether it's after a heart attack, whether it's erectile dysfunction, but actually keeping people talking from the point at which they're no longer in the young and pretty bracket that gets shown, from that point through until the stage at which people need it. So it then doesn't become something that has to be reopened, but something that just is a bit more normalized throughout middle age. I don't know to what extent that's come up in discussions in the project, but I wonder if that's part of the solution, so it isn't a huge hurdle later on.
Yeah.
I think for me, certainly with some of the outreach work that I've been doing with older LGBTQ+, certainly some of the patients that I've been seeing, you know, they've been 60s, 70s. I have one guy who's 78, you know, and it's about opening up with that question where, you know, you're giving them the opportunity to tell you or not tell you. But even if they don't tell you at that time, you know, you've opened up that door slightly. And then what happens next time they come back to see you, they then feel comfortable and know that actually they're not going to be judged. There's no stigma there from that healthcare professional about, you know, feeling freely to, you know, to discuss those types of things. And I think that's what we need to do. It's like you say, it's about normalising that conversation, you know, saying to people, you know, have you got any issues with sexual intimacy or desire? You know, is there anything we can do to help you? And that shouldn't just be about, you know, people who are 45, you know, who may have erection problems or vaginismus or vaginal dryness. You know, we should be considering that at all life stages rather than just at the start of those things where we know it could be an issue. I don't know if you have anything different.
I think I would totally echo what Stephen has said. I think it's important that we start talking about sex, sexual health, well-being, personal changes throughout life. We probably actually need to start this earlier.
Yeah.
We probably need to take it back to school. And certainly in the UK, there is what we call a sexual relationship education programme, but we probably need even more than that. And what we probably do need to say is actually it's fine to keep having sex, or it's fine to stop having sex and then restart having sex, or it's fine not to have sex at all. I think it's important that we have that dialogue. And I think with Shift, what we wanted to do was just remind people it's okay to think about sex, physiology, anatomy, any other bits, emotions later on, and not just neglect them. So I agree. I think looking at, if you want to look at the whole life course, we probably do need to take it back. But I think where we start with Shift now is we can definitely take things forward.
So we need to take a bit of the ick factor out the younger people.
Totally, totally take the ick factor out. I think there's a question from Adam.
I wanted to ask, what word would both of you describe the Shift project in one word?
Good question.
Sorry to put you on the spot.
Just one word.
Fantastic question. Admittedly, I can't fill in the word cloud myself yet. I know.
Yeah. But the trouble is, there's so many different words, isn't there? And just to pick one, I suppose, for me, positivity.
And for me, conversation. Need to talk. Doesn't matter what about, we can just talk. If we can hold a conversation, it'll go as far as it goes.
Ooh.
Of course you can.
it's not a question, but more, I chose dialogue. Dialogue.
Yeah. Fantastic.
What you said, it's very important to invest in preventing.
Yes.
I'm a community worker, so I work with a lot of groups, a lot of different cultures. And the thing is, from generations, they gave us certain ideas about sexuality.
Yes.
Yeah.
And talking about is a very big thing.
Yes.
So my idea is, I think, if we invest in research or dialogue to set the mindset in a different way, we can make a big difference in parenting and talking about things more easier with our children in the future.
Definitely.
Dat is only extraatje erbij.
Just a plus.
Just a plus.
Yes.
Yeah.
So inventing in dialogue and research about to change the mindset can make a big difference.
Absolutely.
Yeah.
And I think with Shift, as you'll hear later, we've done quite a lot of the outreach work, going into communities, trying to get communities to come with us. I think we recently did a Gurkha event.
We did, yes. So we were invited to an event in Folkestone where new families from part of the British Army, the Gurkha Regiment, come in every few years. And obviously for us, you know, it's a different demographic of people, you know, obviously culture is very different, you know, how they approach sex and sexuality is very different. So it was really nice for us to be able to interact at that event, and mostly the husbands weren't there, it was mostly for the wives. But what we found, it was our way to get in the door, you know, to even just begin that conversation, you know, at looking at, and it wasn't just, you know, about contraceptive needs, you know, we were talking to the older ladies, you know, with regards to some of the issues that they've found. And it was finding that time just to have that conversation, like you say, opening that dialogue, you know, taking that time to look at these groups, you know, where, you know, these people aren't going to come into our traditional clinics. You know, we have to make that effort to go to them. And it's so important that we do, you know, as you say, to open that dialogue, start from the very beginning, plant those seeds, you know, that what you want to do with your sex life is fine. We're here to help. You know, you can talk to us, and that's where we need to get to.
And that community event also included things like blood pressure checks, lots of local information. So it became a community thing. It wasn't just singling out talking about sexual health. It was kind of an inclusive event. So those type of things, I think, like you say, opening dialogues and widening the scope is the way to go. It includes sexual health with physical health and mental health.
We sneaked in the back door with health visitors, health checks, because it may not be that we would have been accepted at that event just being there by ourselves, you know, so we had to go with other people in order to kind of get our messages in there and just make people aware that we were there.
Just before we take your question, we've got one online. First of all, the moderators want me to let you know that all the recordings will be subtitled when they're released following the end of the day. But there was another question on here, and I don't know how to get back to it. I wonder if our team, it was about NHS health checks and including, I wonder if magical tech people are able to get me back there. Ah, wonderful. Okay, so we've just had this, and then we'll go to your question. Could these, so it's by Farhat Rahman, and the question is, could these conversations be part of the NHS health checks program in order to reach the older population? A broken heart due to sexual taboos and an unfulfilled sexual health life may be as bad as a broken heart through a heart attack.
Very true. It's very true. Part of our public health division is Kent Community Health. Part of our division is adult health improvements with health checks. So we are currently working with them. You know, we're trying to work in more synergy with them in order to so that their adult health improvement workers can start those conversations and actually help to signpost to us, signpost to our website, signpost to Shift. So we've given them our cards and our QR codes and done a little bit of training with them.
And training, absolutely.
Because they will go into places where necessarily we're kind of, not that we're not welcome, because we're always welcome, we're friendly people, but sometimes it's a bit harder for, you know, sexual health specialists to get our foot in the door, certainly in the UK, you know, because there's lots of events where it seemed that it's not appropriate for us to attend, unfortunately. So yeah, so we've done a little bit of training with them to try and get our foot in the door, certainly in Kent and Medway. I'm not sure, obviously, about the rest of the UK.
Does somebody want to throw the catch box to the lady in the yellow in the back? Thanks, Bim.
Hi, Monica.
You're not going to throw that up.
Or walk it to her.
Hi. Well, that was part of my question, really, because I work as a nurse and a GP here in the area. And how do you manage to reach the GPs and the nurses? Because we find it very hard to get in touch with them and train them. It was easier to train the people in this area than training the nurses and the GPs. So did you have a strategy here or
so I think
in the UK?
Kind of later on this afternoon, you're going to see a little bit around the educational side of Shift. And I think that is really key in terms of changing that knowledge base, widening the information circle that's out there. So, for example, like people who work in general practice, people who work in community health, people who work in specialties where sexual health isn't really discussed. But we want them to be able to access this training, which is free online. And you can also contact colleagues more locally who can deliver face-to-face training as well, the same in the UK, where we then can be able to provide that information, open that conversation, and help improve the dialogue. So in a way, as we say, training healthcare professionals and what we call the wider workforce, people who engage with the community, and also educating, increasing the knowledge, increasing the awareness of the community population itself.
And as Bunty said, it is all on the Shift webpage. You can do, and you can request people to do face-to-face training if you wish to. Equally, I am happy to travel as well.
A little bit of a plug. We do have one more question online. So the question is, I do find it very important that you said communication. Does this not start in the household?
Very good question. Communication is usually between two people. And I think it's important to understand that everybody has a personal, individual knowledge base, personal, individual comfort zones. So like we've been talking a little bit about the eek factor about children thinking their parents, I could be an older child and thinking about my parents having sex. And I think some of those discussions are possible, but some of those are definitely not possible, especially if there are cultural differences, especially if there are gender or sexuality differences within the household. So some conversations are not safe to have, and we wouldn't want to put people at risk of having unsafe conversations. Therefore, coming out into communities where Shift is available, people have been trained, people have been supported, is always going to be welcome. But in an ideal world, we'd love everyone everywhere to be talking about sex all the time, is what I do. But we totally understand it's not possible. And I think it's very individual on the circumstances, whether the people feel comfortable in talking, and if they don't, please don't. But if you do and you want to sow the seeds or leave a website open on your laptop or, for example, show some of the Shift films, often those can open up that communication and dialogue.
I think you're right. And I think, you know, organisations, certainly ours, you know, who provide relationship and sex education. I think you had a really good idea earlier, you know, about younger people being taught about sexuality, sex, intimacy at different life stages throughout, so that actually they're not embarrassed about it. They realise that as we get older, we all have sex. You know,
absolutely.
We have one more
Oh.
question stroke comment. It's more of a general highlight, I would say, from the website. Not from the website, from our online guests, from Emma Davis, who says that they completely agree with what is being said now. How you grow up from a young age and the early conversations you have do shape your views and feelings as an adult, and they're really difficult to change. So I don't know if you guys wanted to respond to that.
No, I think as Stephen just mentioned, I think, and as I mentioned earlier, I think it would be great if we can go further back. Obviously, Shift is starting at 45, moving older, keeping the conversation open, keeping the tide going. In a way, we'd love to roll back, be able to change what school education is about, able to have those diverse conversations, able to do kind of sex education, relationship counselling at a more kind of in-depth level, accepting all the cultural differences, accepting gender diversity, sexuality diversity. But yes, hopefully at some point we will, and we do appreciate that older generations have a certain mindset versus younger, and we hope that by expanding information to all, we can start to change people's mindsets.
I think you're right. I think, you know, we all talk about, certainly a lot about being inclusive everywhere, but actually we're only inclusive to a certain point. We're not inclusive when it comes to age, and I think we need to get better at it.
Definitely.
Just so we do a quick time check, we've got 10 minutes left, so if you have any burning questions, do think of them now. But we do have one more really interesting one, actually, that's come through from the internet, from Isabel Carrick. Apologies to all of you online if I'm getting your names wrong. So it's a long question. Is there an element of healthcare still being a disease-focused deficit model and not holistic? So for example, someone's long-term condition such as CVD, maybe CPD, is viewed by professionals as the main issue, and then there's a sort of assumption that if that's okay, then sexual health isn't important. And then this person has just written, COVID pressures will also have impacted on this too. So I guess, yeah, let me know if you want me to read it again.
Hey, you.
Okay. So using the example that's just been given, someone has a chronic condition like COPD or chronic obstructive pulmonary disease, diabetes, prostate cancer, breast cancer. A lot of these conditions are quite long-term, and some doctors will focus very much on that condition and say exclude sexual health and well-being after that. Hopefully through Shift training, what we want to do is basically improve that and kind of say that, yes, someone might have chronic obstructive pulmonary disease, COPD, sex will still be possible, but these are the things they need to be aware of. For example, I think Dr. Hinchliffe talked about prostate cancer, therefore having that open dialogue of the fact that, yes, you're going to have an operation, we're going to cure the prostate cancer, however, there will be problems with your erection. Diabetes, one of the commonest, fastest rising chronic conditions in Europe. Lots of people are going to be diabetic. It does impact sex. It does impact feelings. It does impact well-being. So again, having those discussions about, okay, how are your sugars? How's your diet? How much weight have you lost or gained? How's your cholesterol? Those are some talks. But actually, we might be talking, actually, it hurts when I have sex now because I've got lots of irritation down below, or my erections don't happen. Having the kind of holistic discussions, the wider discussions are what we need. And yes, unfortunately, it takes time. And we talked about COVID pressures. A lot of things, people are finding it difficult to speak to their GPs or difficult seeing or accessing doctors. But we need to overcome these things in order to be better, certainly health professionals. We need to work better. We need to spend the time. We can do this, but it takes time.
I think you're right. I think, you know, many years ago when I used to work on wards in hospitals, you know, it was a question that was never asked. We never spoke to somebody about their sexuality or their sex. And, you know, it's been many decades now since I've been there. However, things haven't changed. You know, my father had a stroke 4 years ago, and, you know, nobody spoke to him at all with regards to sex. You know, nobody spoke to my mum about, you know, sex, how that would affect her, or, you know, what did they want to do? Was there any help that they could access? And I think, you know, like Mani said, you know, there are certain elements, you know, certain little pockets of hope within the UK healthcare system where those questions are being asked now, but they're few and far between. And, you know, it's like we've been saying all throughout, and Sharon is saying as well, you know, we need to get better at starting that conversation. We need to recognise that there are health conditions, and those health conditions are really important. But actually, if we want to truly look at somebody holistically, we need to get past that disease or that condition and look at the other things that will affect their life, you know. And Shift can help that start. You know, that website is there, the training is there for the wider health workforce, you know, and we need to, you know, get that out there.
Great, thank you. Any questions in the audience before I read a comment from our online guests? No, in that case, I shall read it. It's a comment stroke question again from Leslie Talbot. We have young people's sexual health clinics and services. Makes sense, or would it make sense, maybe, is the question, to have older people's health clinics? And why not add a question when coming for routine bloods and vaccinations, for example, to take some time to talk about healthy lifestyles and personal experiences?
I think that's right. Certainly within our sexual health clinics, we have a question surrounding intimacy and any issues, you know, desires that may not be functioning. You know, so again, you know, when we first introduced that question, the looks we got from patients, you know, they were like, why are you asking me that? You know, you've been really personal to start with anyway, asking all the different things, but actually that one's a bolt out the blue. It's a strange one. I'm only here to get tested. And as we said to them, you know, again, it's about us opening up that forum for them to be able to talk about things, you know, because all too often we have that 20-minute consultation. We have to get through a certain amount of things because we've got to get to that end goal of why you're here. But actually, that's our opportunity of making every contact count, you know, and looking at, you know, what else can we do to help you? So, yeah, certainly from us it does, but I'm not sure with regards to other sexual health services whether they ask those questions.
Great, thank you. That actually is going to be the final, your final bow.
I thought you were going to keep it forever.
So if you'd all like to give just a warm round of applause to Dr. Munyan Tung and Stephen Grice. Great. And now you can both enjoy the rest of the day. It's okay, you can say we're done. So I was just going to say, we're going to have a break now, which means here from 11:10 until 11:40, and if you're joining us from the UK, from 10:10 until 10:40. There are a number of questions that have come through online that we haven't had time to answer, which is great. We're really pleased that you're so engaged. We will do our best to either answer them in the afternoon if there's any additional time, or we will, if you leave an email address or a method of contact, one of us will endeavor to respond to you. I think that's everything I was supposed to say. Let me just check with my production. Yep, they've given me the thumbs up. So half an hour, come back, and then we will talk a little bit more about outreach, which will answer maybe some of the questions you've already had. So enjoy your break, everyone.
Well, welcome back. My name is Wim Zuiloff, and I work for SOA AIDS Nederland. And I will be the host for the next 65 minutes, which will be about working with key populations, doing outreach with key populations on sexual health. And the 65 minutes consists of two parts. One is a keynote speech by Maria van der Muizenberg, professor in public health here in the Netherlands, and that was pre-recorded. And after that, there will be a presentation done by Amanda, known inmiddels, and my colleague Tatjana. And after the two presentations, we will have a short Q&A here on stage, the three of us. But let's first look at Maria Muizenberg's keynote speech.
Good morning. My name is Wim Zuiloff. I worked on the SHIFT project on behalf of SOA AIDS Netherlands. And it is with great pleasure that I now introduce Maria van der Muizenberg. Maria is Professor of Health Disparities and Person-Centered Integrated Primary Care at Radboud Academical Medical Center. She also works as a general practitioner and for VARUS, the Dutch Expertise Center for Health Differences. And apart from that, Maria is also the chair of the European Forum for Primary Care. Maria's keynote speech focuses on inequity in healthcare, also when it comes to sexual health and how to overcome this inequity. Maria, the floor is yours.
Thank you very much. It's an honor and a pleasure that I'm invited to attend this conference. Unfortunately, it's by Zoom. And as you so very nicely put it in your invitation, this is about people who are not equally seen, not equally accepted in society. And that's one of the reasons they suffer from inequities in health. In this issue, in this conference, we address, of course, the inequity in sexual health and health care. And the question you were addressing, and you very well addressed in your project as well, was how we can shift services from clinics, STI clinics, to communities, and then in specifically, how do we reach those most at risk? And we know that always those most at risk are always the same groups that suffer the most from societal disparities. But we want them all, in all their color, in all their differences, to be accepted, to be reached, and to have the possibility to have good lives. And therefore, we want to organize our organization or our society so that we reach all. And what I will try to convince you of or to discuss with you is how community-oriented, integrated care and services nearby the patients, nearby the persons, so it's in their own community, have the ability to include all. As we unfortunately have seen very recently in the pandemic we suffered from the last years, it came apparent that in such a pandemic and in such a time, health inequities only increase. And where sometimes our government tried to convince us that we are all in it together, it was very clear we were not all in it together. There were huge differences in groups who are less advantaged in society, who suffered the most, not only in terms of death and illness, but also in social consequences from the pandemic. And as you also in your project has experienced, it was difficult to get people together and especially to reach the people who are working in healthcare. But these health inequities, we don't see them only concerning the pandemic, we see them in all aspects, also in sexual and reproductive health. For instance, we know that ethnic minorities and poor people in all societies are most affected. They suffer the most from sexual transmittable diseases, sometimes because they origin from countries where there are these diseases like HIV or hepatitis B or C are endemic, but also because often their circumstances force them or enable them to have unsafe sex, and they suffer also from lack of access to health care. And so, as you see here, the birds, we are not all at the same line. Some have more possibilities than others. For instance, in the Netherlands, we know that the uptake for STI screening in STI clinics ruled by the public health authorities are far less than of other people. And that as we look where people are more found, that in primary care, ethnic minority people with complaints or problems regarding sexual health, and also people with less money or less education are seen more often. But still, we are not always able to reach them as they would deserve. And especially not those who are the most hidden in our societies, like undocumented migrants. And this is what a patient of mine said to me at the time. She was an undocumented refugee living in the Netherlands with her daughter, and she suffered from a severe STI due to forced sex, which she has to accept in to gain a home, to gain a shelter for her and her daughter. So these are the people we are thinking about most when we're talking about hidden faces, hidden groups. what does these health disparities, not only in sexual health, but in all kinds of health, cause? Well, that's a accumulation of chronic stress due to little money, worries about finances, worries about housing, worries about finding friends, finding surroundings that are supportive of you, lack of social support. In the case of migrants, often we see that the challenges they meet in a new society add to this stress. And this stress, which is caused by social disadvantages, but also adds to those social disadvantages because, for instance, when you have little money, or when you don't speak the language, or when your own values or cultural norms are not in line with those of the majority surrounding you, that also leads to more problems in accessing healthcare. So what we see is that people, and we see it every step lower on the social ladder, and especially when you have also a migration or an ethnic minority background, leads to more diseases, because chronic stress is very unhealthy for you. It causes a lot of diseases, and it leads to less access to good quality care, because care and service are often not tailored to the needs of these people. When you are not able to read or write, when you don't, or you are not as fluent in the language of the majority of you people, of course it's difficult to know where to go to access services. So a lack of information, where to go, how does this function, where can I find information? Financial barriers, also healthcare, also in a very rich country as the Netherlands, there are lots of financial barriers, sometimes because people like undocumented migrants are not allowed to have a health insurance, but often because this is too expensive. There's a lot of out-of-pocket money. So financial barriers, but also barriers in it's too far to reach, or you don't know the way to find people. And then when you have reached a healthcare provider, often the services he or she is offering are not tailored to your needs. For instance, they are not sensitive to your values, to your what you care most for, or they don't know how to discuss it in an understandable and acceptable language. So this is what we see. But we know also that person-centered, community-oriented, integrated care can reduce health disparities. And what do we mean by this? We mean by this that it's a person-centered care that is rooted in local communities, in a neighborhood, in a small village, but in the local communities, knows that communities, but is also reaching out to the ones in that community. It's inclusive, it includes all, it's aware of its own biases, but tries to overcome them. It's affordable, no financial limits, and it's accessible, not only physical, that's very important also, but also in the ways of information and acceptability. And we know that such a person-centered, cultural sensitive care, by which we mean that it's oriented at the goals of the person, of the patient, and not at the disease. So when you come there with, for instance, a problem related to sexual health, it's not that the doctor is focused only on, oh, this is this disease and nasty and whatever, but it's also oriented at, oh, how's that for you? What is the importance for you? What is your most important goal that you want to achieve now? And to discuss that. It's needs and values driven, and it's engaging patient and community only by asking people, what is important for you? How do you think about this? Is it possible to address really their needs and to get into contact and to forge this very important patient-provider bond that is needed in order to be accepted by patients as a caregiver. And we also know that this kind of care that is tailored to the needs of all the diversity of patients that we encounter leads to better health outcomes and more equity in health and in healthcare for lower costs. And now we see that when it comes to all kinds of issues related to health, there are many good examples in community activities. Like in your SHIFT project, I was very impressed by what you achieved here in the Netherlands in the Schilderswijk. And here I have a bit of fake photograph of a group of refugees who come together on gender-based violence, organized by Zara Kazai, a refugee herself, in a collaboration with Doctors of the World. And I see this is another example in Amsterdam, but so we see lots of good examples. And the question now today is, how can healthcare, that person-centered, community-oriented healthcare that so ideally would take place, connect with those community initiatives? Because we know that when a community is committed to something, it's much more effective. And we would like to combine this with the healthcare that people also need or want to access. The most important issue here is that we do this through community key persons. The only way to reach, especially those most in need of reaching, are those who know the community. And here you see a picture of such key persons that were trained some time ago in the Protect project on also on sexual violence amongst refugees, but that can also be a key person from a church or a mosque, or from a women's group at a community center, or, well, you name it. But you have to find those people, and they will guide you to find come into contact with their community. Hereby, it's very important that we are aware that not one size fits all. As you also have seen in your project, and we have the same experience in many other projects, that it's sometimes, when it comes to health promotion, it's not easy to involve men. And the interesting thing is that we also have some experiences in initiative where we well achieved to involve men, but we had to take a different approach. For instance, a small example, we had a project for lonely people in a neighborhood center to cook together. And it was very well accepted. Many women came, and it was lovely, and they cooked together. It was very, very nice. But no men came. And then this was discussed with a few men, and they said, well, like you framed it, it was for pitiful, lonely people. Well, I'm not pitiful and lonely. I won't come. Okay, then we changed the approach, the language we used, and the pictures we used, and we didn't say, are you lonely, come to cook together, but we said, this is man with pans. I'm not sure if pans is the right English word, but the things you cook in. And it was with a very daring picture of a famous chief cook. And then the men came, and they came to cook and to be good cooks. And then in the meantime, they started to talk about how it was to be alone, how they felt lonely. So in a different approach, we achieved also accessing them. But of course, we cannot decide for other people what will attract them. So the only way to know what's an effective approach is, again, to ask people, to approach them and to discuss with them what would be for you a nice way to do this. And of course, always, and that's very, very difficult for highly educated people who usually are in the lead in healthcare and services, to use understandable and accessible information. And that mean, for instance, that when you are working with people who have a migration background, that you involve interpreters. But it means also, for instance, that you don't use email or a website for approaching people, but for instance, WhatsApp, because WhatsApp is for free. WhatsApp is people who look at you, they know you are the person who is going to contact them. So that's more trustworthy. And this information has to be found in places they visit. So, for instance, at the cheap stores like the Lidl or something like that, and in the churches, in the mosques, in the community centers. And it has to be very easy, understandable information. So using pictures that are tested with the people who have to use them. For instance, you all know it, I saw it also in your project. A very good example is the website when it comes to sexual health of Zanzu. With very clear pictures that can be understood by everybody, regardless of the language. And we also have to make sure that the information is in line with what people find important, because it's very important always to be aware of the taboo and shame. I think when it comes to STIs or sexual health, we all know that some people more than others, but many people feel a taboo or feel ashamed to talk about it. But that is also when it comes to, for instance, the issue of financial debts, problems with finances, or with the ability to read or write. So all these issues we know that people are ashamed of or have difficulty to share, or are very much afraid that their own family or their own community will become aware of them. We have to be prudent to go around this. So not, for instance, say to everybody, well, you have to tell your family this, or you should involve your family when they don't want it. So always ask what they want, but also by normalizing it. It helps, in my experience as a doctor, it helps a lot when you tell a person, well, I know that many people, I have many patients who have suffered from this disease, for instance, and I know it's people don't like it, and it's probably something you are ashamed of, but you can discuss it with me. I will talk to nobody with it, about it, but I'm very familiar with the problems that are surrounded with it. So that's a very important issue, also to give people the feeling that you really accept and trust their own values. But of course, when we want to engage as a healthcare professional or as social care professionals with the community, there are some conditions that have to be met, and they are very much related. And of course, as always, money is a big issue because we need time, and time is money. And not only we need, so for instance, in healthcare, it would be very important that we get paid, adjusted to the needs of our population, and also be paid for the time we have to dedicate to collaboration with other professionals and to reach out to the community, because time, money, and interprofessional collaborations are the necessary conditions to enable us to reach out to the community. But most of all, of course, as always, is that we have a heart to do that. Only when you really feel that it's important to reach your patients or to reach the community, that you feel how marvelous it is that they have all this kind of energy and projects and initiatives, and how wonderful it is to connect with them and to build something together, that will give you the energy, and so it will give you the time and the possibilities to reach out. And then we know that it's everywhere, in all circumstances, possible to include everybody. Here you see a picture of one of our projects in which we provided a primary care for refugees in at Lesbos, at the refugee camp, and it was very difficult at that time, it's a long time ago already, 2016 to reach them. But you see here our general practitioner who met these people and talked with them about their health and about the healthcare service that they would need. So it is possible. And if we achieve to reach out to those people who are usually hidden in our societies, who deserve our attention and our care and support most, then we achieve that we lessen the health inequalities that exist, not by giving everybody the same, just waiting until they come because they know they can come to you, but they don't, but providing them with what they need, and everybody needs something different. If we can do that, then we reach equity and in the end, a better health and happiness for all. Thank you.
Oh, okay. You're coming up too. Okay, thank you. Again, it feels very strange to thank somebody who's not in the room, but thank you. And I think that actually the presentation that's going to follow will really complement the words of Professor Maria. So very interesting. Now I'm actually going to introduce myself again and my colleague Tatiana, and we're going to talk to you a little bit about the outreach section of the SHIFT project. Yeah. Or do you want to wait until your part?
I think that would be better.
Okay, no, I'm not going to introduce Tatiana. She's just going to wait for a moment. So I was really pleased when I found out that the section that Tatiana and I got to present was around the outreach, because outreach is something that I've done. Community outreach or engagement is something that I hold really dear to my heart, and it's really been one of the more pivotal aspects of my career. And I think the reason that I like it is because you get to interact so directly and so intimately with people. And often we talk about people who are in need or people at risk or people who are vulnerable. We use these really sort of negative terminology, but actually when you go out into the communities, what you see is joy and beauty and strength and resilience, and then we sort of support people to build those things, and I think it's really rewarding, and I'm so pleased that within the kind of the boundaries of the SHIFT work, we were able to include such amazing outreach. So we've heard about why it's important from Professor Maria to engage communities and those most vulnerable. Unsurprisingly, when we came up with the SHIFT project, we recognized that there was going to be two cohorts of people, the general population, which Manye and Stephen spoke to you about earlier this morning, and the people who are more at risk. And so we, in Work Package 2, using SHIFT terminology, we wanted to engage those who are more at risk of having poor sexual health outcomes. One of the things that we know, which again, I think you, Sharon, said this morning, and I think Professor Maria said it as well, is that we know that there are the same groups that come up over and over and over again as being more at risk of disadvantageous health outcomes, whether it's sexual health or mental health or physical health. We know that there are certain groups who are more at risk. So we wanted to break that down a little bit when we did the SHIFT research. And you'll hear a lot more about the research and evaluation this afternoon, so I won't go into too much detail. And I certainly don't want to take away from the presentation later today. But what we learned is that in addition to the knowledge, awareness, access, and stigma that Manye talked about, and in addition to the things that my colleagues, our evaluation partners are going to talk about this afternoon, that there were some really key outcomes or key findings for some of the more vulnerable groups that we identified. Unsurprisingly, and we've spoken about this already today, some of the issues were cultural norms and taboos. So intergenerationally, what myths were shared, what beliefs were shared, where were the stigmas, where were the biases, those sorts of things. There was a huge fear of disclosure, there was a huge fear of diagnosis because people then worried that it would come with a disclosure. So I don't want to test for HIV because I don't want to be diagnosed with HIV, because how will I tell my family that I've got HIV? There was lots of generational views, both for and against, but generally against. You know, we don't need to bother, we don't want to know, that's not for us. There were fears of racial discrimination or sexual or gender orientation discrimination within healthcare, often based on lived experience, so often based on previous experiences of having been discriminated against. Huge concerns about anonymity and confidentiality within communities, particularly smaller communities, where there's a belief or a perception that everyone knows everyone. So you go to the doctor and you talk about I don't know, something, and then the doctor knows your mom, and she tells your mom, who tells your auntie, who tells your, and people really worry about that. there was an additional concern when we looked at translation. So, okay, so doctors and nurses and healthcare providers might need to be confidential, but what about the translator who's there? What are they going to go out and say? So some of those things come up. And then previous bad experiences I've already mentioned, and they were rife and sad but unsurprising. Again, as you said this morning, Sharon, and I think as Professor Maria just said as well, there are some of the groups that we are always looking at. And in sexual health, these are the ones that we tend to look at. So people identifying as LGBTQ+. Although I will say, with a bit of a caveat there, that men who have sex with men or MSM are often very well catered for in sexual health. It's the other, so the lesbians, I'm trying to think, the lesbians, bisexual women, people who are trans, and people who are queer or questioning who often get neglected. People from BAME backgrounds, people living with or affected by HIV. I think there's a real misconception that because somebody is diagnosed with HIV, all of their sexual health needs are taken care of, and I can tell you that certainly isn't the case. Sex workers, people who are homeless or poorly housed, refugees and asylum seekers, people living in poverty, people who are geographically isolated, and people with physical or mental health disabilities. So basically anybody at risk is who we were trying to find. Very interestingly, so there was 2 partners in the project who are sort of community experts, and I know Mani spoke about why it was important that we all came together in the way that we did. Metro Charity, who I'm representing today, is based in London in the southeast of the UK, and we have a very strong LGBTQ history, as well as a big history in HIV sort of advocacy and awareness and progress. So AIDS in the Netherlands, Tatiana will tell you a little bit more about them shortly. But it was quite interesting because we had the same task and we approached it very differently. Some of our outcomes were very similar and some of our outcomes were very different, which is, of course, fascinating. So we knew that we couldn't do everything, and we had a lot of time limitations, and COVID certainly didn't help because we couldn't actually go out into communities. So we kind of narrowed our niche a little bit, and we focused on people who were LGBTQ, people who are homeless or poorly housed, people who were BAME, and people living in poorer areas. And that was largely because those were the easiest groups for us to access because we already had inroads. And as Professor Maria said, one of the key things when you're doing outreach is being able to actually get to people. And it's easier to get to them when you already know them. So that's why we selected those groups at Metro. We had a lot of strengths. I'll come to the limitations in a moment. I think our biggest strength was that we have, people are really aware of the Metro brand, particularly in LGBTQ communities and in the southeast of the UK. I think we're known as a very inclusive, equitable, kind of non-judgmental space for people to come. And so I think that our brand or our image really boded well for us. We have strong connections already within the community. So relationships that have been built over years and years and years, where sort of we know if we say we'd like to come and do X, there's a trust that we're going to be able to deliver and that we're going to take care of that. We have our connections with the local authorities. So some of them are in the room today. So thank you guys. They were really kind of critical in making sure that we got to the right places with the right permissions. And we also, at Metro, we have a lot of other services that were linked. So we work in mental health and well-being, and HIV, and youth services, which wasn't relevant for Shift, as well as in community engagement. And so we had a lot of existing groups or networks or contacts that we were able to kind of pull on to say, hey, let's talk about sexual health as well. Yeah, and I think that the other key thing that we look at with Metro, and this might come up with Tatiana as well, is that we really have a good staff team who are good at outreach. And we talk a lot about community outreach, and I see people all the time with, their smoking buses or their blood pressure buses, and you've got staff sitting there on their phones behind a table with no signage, no messaging. We at Metro are really, really good at making sure we get the right staff out into the right places. And one of our staff is here today, so you can ask some questions about how it all went later. You can give us some honest feedback. The limitations in this project, I was joking for a while that this felt like the cursed project, because every time we planned something like COVID came along, or something smaller like a train strike, or we couldn't go on the train because there was a leaf on the railway and we couldn't get to the event. It was just crazy. So there was a limited time that we had compared to what we would have liked. It's really difficult within local authorities who aren't engaged in the work to give you their attention. So although we focused most of our work in Kent and Medway and in East Sussex, because we had connections there, we would have liked to have branched out more, but we just didn't get any engagement from the local authorities. And I can tell you that I tried and tried and tried and tried, and I'm very persistent. Some of the locations that we went to, they were great in terms of statistics. So if you looked at, your statistical map, you would say, yep, there's, high vulnerabilities here. But when we went there with our bus and parked up, there's no traffic. So it's great, yes, statistically, but actually, if there's no people there to talk to, you can't do outreach. We had, I won't even go into the train and travel delays. It was almost comical at some points. There was always, as well as, Metro is a charity, there's always a capacity issue when you're a charity, and trying to take people away from, their commissioned work or their kind of longer term roles and get them to engage in something that is, totally different for them and not part of the job description can sometimes be difficult when you're already feeling, quite burnt out, particularly after COVID. We, as well at Metro, as I said, we have a lot of existing groups, but a lot of our work is focused in London, which isn't one of the areas of Shift, or for younger people, which is, of course, also not one of the areas of Shift. So we really had to sort of force ourselves to branch out and think about things differently, use connections in a different way, and approach things, differently than we used to. And again, I spoke about staff. We have staff who are really good at supporting young people. And of course, engaging somebody who's 18 is going to be very different than engaging somebody who's 88. So how do we give those skills in a very limited time? So that's one of the things we came up against. What do we actually do? We managed to achieve, and we were very, very proud of ourselves, and I hope that you guys will realize what a remarkable achievement this actually was. We had 3 sessions at local Pride events. We took our health bus around to 3 locations across Kent and Medway that we knew, and Brighton, that we knew were areas of deprivation. We held a bespoke session for women of colour who were living with HIV. I think there were 7 in the group, predominantly from Black African backgrounds. We did 2 drop-in sessions, which were very ad hoc because the bus was rained out, so I had to find something to do with, with my time. So I popped into the local homeless shelters, and we actually had some great sessions. And then we actually had 1 ad hoc session after a Pride event at a local bed and breakfast because people found out what we did and there was so much need. They were inviting their friends over and saying, you got to come and meet this girl. She's talking about sexual health. Bring it. So we turned out to be, it was quite an interesting session actually. I'm not going to run through the statistics. For those of you who are online, you can read them. The presentation is going to be uploaded at the end. And I should have said as well, we had to abridge it a little bit. So there's a few more slides at the beginning for the presentation online that is just about why we picked the specific group. So it goes into a little bit more about people who are homeless, people who identify as LGBTQ, and people who identify as from a Black and ethnic minority community, Black or ethnic minority community, and why that was so important to us. But we don't have time today. But what I will say is that we managed to reach almost 3,000 people in total, which was brilliant. And we managed to have specific conversations with about 350, just under 350. And we managed to have what we would consider health promotion interventions with 54, which is actually really good outcomes for outreach. We actually saw a pretty good balance of men and women, but I think that was likely because we did so much at Pride, and there's always a big cohort of men at Pride, so I think that was how we got our gender balance right. We had, obviously, being at Pride, lots of different sexual orientations, gender identities, different types of relationships. We had everyone and everyone coming to us, which was brilliant. We actually had really, really good engagement from people who were homeless, and interestingly, so a couple ones we did at a shelter, and a couple ones, or different shelters rather, and a couple of the other ones, we actually had homeless people come up to the bus, and they found us so welcoming that they were running around Brighton, finding their other homeless friends and saying, you got to come get free condoms and get free lube. So they were going around to all the various corners and locations and bringing people, which was brilliant. We saw a lot of people with disabilities and chronic health conditions. I think this is particularly in Kent, and I think it's because we were in areas of high deprivation where there was a generally much older population, and we know that as we age, our bodies often start to lose their mobility and issues crop up. We had a really good age range. I'd say 45 to 85, but actually I think our oldest was 87, and she actually came to us and said, you know, I've been trying to date, and I just don't understand why it's not happening. I even went on first dates, and my only criteria was having somebody who was taller than me, and they gave me somebody up to my chin. So I think we actually had somebody a little bit older than 85. She was pretty funny. We didn't get a lot of BAME engagement, and I don't know why. Maybe the location, maybe the time of day that we were there. I just don't know why, but we really didn't reach almost anybody that we would in that group. We didn't have a lot of people who identified as having mental health issues, although many of the people who passed by us clearly did have mental health issues. Some of them didn't really welcome our presence, I will say. We didn't see a lot of people with drug or alcohol abuse issues, although probably if we looked a little bit more closely into the homeless shelters, we might have found a little bit more there. I saw no sex workers, at least not to my knowledge, nobody from Gypsy, Traveller or Roma communities, again, at least to my knowledge. And we didn't see a lot of refugees and asylum seekers. Although it's interesting, Tatiana, that you had the opposite. So Tatiana will come in a bit. What we learned, this is what is the most important part. I'll let you guys read through the slide, but what I will tell you is that what I felt or what I sort of sensed was actually quite sad from a lot of people who would come up to us, and often they were women, or often they were partners of women, either male or female or non-binary. And there was just a real desperation of, I've been going through this, I've asked for help, nobody helps me, nobody listens, or you have the alternative, I don't even know where to ask for help, I wouldn't even know where to start. And so you've got, as I said, I think earlier, and when I asked my question, you had a lot of men coming up with female partners saying, she's lost her libido, how do we fix it? Which really tallies with the work that you said about women often going along for their relationship. But we also had a lot of women who, sex aside, were experiencing anxiety, fatigue, sleepless nights, depression, physical concerns, and they just were really neglected. Many had had no experience of care. Those who had bad experiences of care. Many found that they found a treatment that worked, but they couldn't afford to continue it because the way that HRT or hormonal replacement therapy is prescribed can be very expensive for people. And also they found, and again, you sort of said this earlier today, I think, that people were perimenopausal. They were going to their GP with clear symptoms of perimenopause and nothing was discussed. They were put on antidepressants or put on this or put on that. And of course, it's menopause, it's your hormones. So it was really, really sad. And it just really made me realize that we need to focus on this a lot more in the future. I just put a little bit about menopause there. You can look at that way in your own time. The other thing that we observed was that there was a sort of general attitude of a sort of a cavalier, a bit of a bravado that was placed. 1 minute left? Oh, okay, that's okay, I'm almost done. A bravado that was placed, oh, that's past me, I don't need to have sex anymore. Oh, it doesn't matter. Oh, that's the thing that I used to do in the past. Oh, what are you asking me for? Have you seen me? Those sorts of things. Yet when we look at the NATSAL, so the National Survey for Sexual Attitudes and Lifestyle, is that right? What we see is that actually there's a real dissatisfaction with people's sex lives as they age. So what they're saying to us and what they're feeling are two different things. So how do we start to unpick that? If people really are unhappy, why aren't they seeking support? And how do we approach them in a way that makes them a little bit more, I guess, communicative or open? I've only got probably 30 seconds left. We also found with homelessness, a big problem in the UK at the moment is that a lot of testing for patients or clients who don't have symptoms is online. If you don't have an address, how do you order a kit? But there was a real appetite we found in homeless shelters and homeless GPs to engage. And so I think it really is just an issue now of making some good links and building that. We also saw a huge strength in the community that homeless people seem to really support other homeless people. As I say, they were going around getting each other, getting condoms for their friends, getting this for their friends, asking about this, saying, oh, so-and-so needs to come see you. So how do we build on that? Those are my ideas for future projects. We need to look at menopause, we need to look at homelessness, and we need to look at starting to work more closely in how people believe their right to sexual satisfaction and pleasure as they age. I think I've almost gotten to time. So now I will invite my colleague Tatiana up, and then we'll together do a Q&A at the end.
You're
welcome. Do you want me to pass it down?
Okay, so my name is Tatiana Moebati. I work at SOA AIDS Netherlands. And for people who don't know our organization, SOA AIDS Netherlands is a national NGO and a knowledge and expertise center on STI and HIV in the Netherlands. So Amanda just presented the specific barriers that are people with who are vulnerable experience it actually, but and all of the barriers actually apply also to the Dutch public, but there are some specific barriers that are only mentioned by Dutch participants. the most important one was cost of care or medication. So people who are familiar with Dutch healthcare system, they know that GP care and first-line care, actually, it is free of charge. But when people need a diagnostic test or they need medication, they have to pay up to a certain amount per year. And this is a barrier for many people, or at least for this group of people in the Netherlands. Also, disability and lack of passport or identification for undocumented migrants were also mentioned as barriers, but these were just mentioned by one or two participants, so it was we can't really generalize it. Also, I wanted to say something at the beginning I forgot. So we tried with our survey and with interviews, we tried to involve with people who really have a barrier, have a language barrier. So what we did was that the original survey was in English. We translated it into Dutch, but we also hired a language agency to rewrite the survey and to rewrite it in plain language, A2 level. So in this way, we wanted to attract more people who are more people who have a language barrier. Also for interviews, we try to actually recruit a variety of migrants, so with different cultural and ethnic backgrounds, but also with variety of sexual lifestyles. Amanda also presented a long list of vulnerable groups that we wanted to reach, but we realized that we can't reach everybody, so we decided to focus on certain groups. And in the Netherlands, based on our national priorities and also based on our expertise as SOA-AIDS Netherlands, we decided to reach these groups. So non-native Dutch speakers, first and second generation migrants, but mostly first generation who have a greater barrier, language barrier. People from a lower economic status and people living in marginalized areas, so in neighborhoods where the most of the people have a low socioeconomic status. And when we tried to reach these groups, we had to be less strict on 45+. So we exclude youth, of course. But for example, if someone was 43, she or he was not excluded from our programs. So we try to include everybody who, in this age group that needs our help. The method or strategy that we used was neighborhood-based approach in one of the marginalized areas of the Netherlands. For this aim, we selected Schilderswijk. It is a neighborhood in The Hague. And actually, the venue of that we are today is also located in this area. So for people who live in the Netherlands, it is, I think it is a well-known neighborhood, and they know actually this place, but I'm going to give you some background information. The total population in this area is about 31,000 people. About more than 81% of the population has a non-Western migration background. So a great majority of people, and as you can see, they are mostly Turks, Moroccans, but also from Suriname or other non-Western countries. In this bar chart, you can see the age groups of people. So the two bars at the right are our age group, 45+, and this is something about 12,000 people, so 38% of the total population of this neighborhood. In this diagram, you can see the education level of people, and as you can see, the majority of people have a low education level in this area, and just 13% of people has a university degree, which is, if you compare it with 35% in the Netherlands, it is much lower. And this is the average income of people in different neighborhoods in The Hague. So each of these bars shows one of the neighborhoods in The Hague. And this small bar at the left, this is Schilderswijk. So as you can see, it is, people here have a very, how you say that, they are economically disadvantaged. We know that unemployment rate is quite high in this region. And also there are people who live with minimum income for a very long period of time. So if we wanted to reach these groups that I already mentioned, this was the place to be for us. But besides that, something which was very interesting for us in this area was that here there are well-functioning and well-organized community-based organizations that work here, and they have really committed healthcare professionals and workers. So for us, it was a very good opportunity to get engaged with these organizations. Actually, what we wanted to do was a kind of environmental restructuring. So we planned to change the physical environment of people in order to promote healthy behaviors. And for this purpose, we did a number of activities in collaboration with a community center in this area, the Musa, which I think it is quite unique in the way that they are organized and they work in this area. So what we did was that in collaboration with them, we organized some education sessions for local residents. We trained Schilderwijk mothers. There are a group of contact persons, or let's say, as Maria also said, key persons in this area. There are women who are trained and help other women, other mothers with bigger or smaller problems like financial issues or with filling in forms or parenting problems if they have. So we also train them on sexual health in order to reach other women through them. So women who are not easily reached by, for example, an education session. We trained sport coaches in order to reach other people through them, and especially men. We had planned to organize a STI and HIV testing week. Unfortunately, we couldn't, we didn't succeed due to barriers that I'm going to discuss later. But what we finally did was we had a small-scale outreach, a couple of days, and we could actually reach out women or residents with sexual health consults, contraception, and STI testing. Besides the activities that we did with the Musen, we had some information sessions for undocumented migrants and homeless population in collaboration with World House. And also we organized some education sessions for clients of Food Bank. We did it in collaboration with the STEC, which is Organization for City and Church, if I translate it right. And I talked about environmental restructuring. So healthcare providers are also very important in an environment. So we also train GP assistants, but because we believe that all of these people, they go to GP. So it was a very good way to reach out to these people. We had planned to actually train a great majority of GPs in this area, but unfortunately, we couldn't, and I'm going to talk about it later as well. So these are our outcomes. And I'm not going to read all of them, but for GP assistants, we finally could train 14 people in this area and 30 people in other parts of the Netherlands. So who we saw in our sessions? We saw mostly heterosexual, well, actually all of them, heterosexual women, all with a migration background. They were mostly married. a limited number of widowed or separated people. They were from very different ethnic background, mostly from Turkey, Morocco, Middle East, and Suriname. They were people from a lower socioeconomic status, and they were mostly middle-aged. So we had almost no 65-plus people. And who we missed? Men. So despite Metro, we missed men. And the reason was that we wanted to reach men with a migration background, but it seems that it is very difficult to talk with men, heterosexual men, about sexuality, and men with a migration background is even more difficult. I don't want to say that it is impossible, but you need other ways to reach them. What were our limitations? So the first one, everybody knows that it was COVID. So it was not just for us, for all of the partners. In the original plan, we had planned to pilot the project 18 months. However, due to COVID restrictions, we had to put the project on hold for a while because some of our partners were first-line healthcare providers, and they were directly involved in COVID healthcare. But besides that, because of the lockdown and social distancing, actually we couldn't have our activities for a time. Finally, we piloted the project for 6 months, and this 6 months was also including summer vacation. So we had a very limited time to implement the project. The COVID also had effects on GPs. We wanted to train GP assistants, and we as SOA Netherlands have a very good experience in training GPs on sexual health. This is one of our works that we do every year. But in this project, we couldn't actually do that, the number that we wanted. The reason, I think, was that there is still a very high workload at GPs, partly due to COVID, because there are postponed care, but also because healthcare providers are, a lot of them are sick, so they have burnout or Lyme COVID. We couldn't reach the numbers that we wanted. Also, I told you that we trained Schilderswijk mothers to talk with other women about sexual health. So it seems that talking about sexual health with other women was not so easy for them. We trained 18 Schilderswijk mothers, and from them, 3 of them received also extra training, but they needed more time, more practice, and other approaches. And unfortunately, due to the short period of implementation, we couldn't actually focus more on that. Also, reaching men by trained sport coaches was not really successful, and we needed other innovative ways to involve with men. As Maria said, man with pan. But we couldn't actually do that because of lack of time. The most important observations, as Amanda also said, menopause seems to be a very critical problem. It seems that a lot of women go through this, and they have mental and physical complications, but they don't know where to get help. And we think that this is somehow unmet need. I mean, a lot of women, even they don't know that they can get help for menopause complications. And they think that this is a phase in their life that they have to go through, and the complications are inevitable. We wanted to focus based on the model, beautiful model that Moon Yi just presented this morning. We wanted to focus on different aspects of sexual health. So not only complications of menopause, but also sexual pleasure and stigma. But we realized that actually women here, or the participants of our education sessions, have very basic knowledge about body in general and about anatomy. So we had to take one step back and start from very beginning. And as I said, because we didn't have time, we couldn't really cover everything in these 6 months. And we missed the involvement of healthcare professionals, as I said, due to the barriers that we know, structural barriers, but also due to the fact that, as you are all aware, and it was repeated in all of the presentations, because they don't see the priority and urgency of this issue for this age group. So what we learned, as I said, we had planned to pilot the project 18 months, and during the implementation, we realized that indeed we need more time. We needed more time to continue the project, to support Schilderswijk mothers, to support the sport coaches, to cover different aspects of sexual health training for women. We learned that community neighborhood-based approaches are very successful, can be very successful and powerful. But one of the most important preconditions is that that in the area that you want to work, there are good, well-organized community organizations, and this is very important. And this was a project that is funded by European Union, so we had to set the goals and deliverables months ago, but so we couldn't actually, principally, we couldn't at that time involve with the healthcare professionals in this area. But it would be very nice if we can actually involve with the healthcare providers and community workers of a specific area from the very beginning to set the goals based on their local needs and then to start the project. So some ideas for future. My time is, Wim? 1 minute, okay. So we have to try to practice more attractive, man-appealing approaches to reach migrant men. We need more intensive neighborhood approaches, so we really need to do environmental restructuring and involve with all of the local parties. And we need more combined outreach, as also was mentioned in the presentations before me. So not only on sexual health, but to actually combine it with other aspects of health. And what we are going to do is that we are going to publish and disseminate the outcomes, the strategies that we have used, and the success factors that we have actually found. And we are going to work with local authorities and local decision-making bodies to put this subject on their agenda and to create project opportunities. And we are also going to work more with healthcare professionals to actually involve them more and to direct them to our outcomes and our trainings. And this is my last slide. I think it is obvious, so you can read it yourself. Thank you.
Where's the laptop?
Okay, well, thank you. I just want to do a quick, what's the time?
We'll do the break 5 minutes later than planned, so 50 instead of 45. I hope you can endure that. That gives us a little time to do a short Q&A. Up to now, I don't have any questions from the people outside the room. Are there any questions in the room too? Or reactions to Maria, or questions to Amanda or Tatjana about the presentations? Yeah, Sharon?
Oh, yeah, where's the box?
You need the
you need the box.
Ball or
ready?
Oh, yay! Thank you. Yeah, I just thought that was really interesting about how you did the outreach work Because I know it can be quite challenging, can't it, to get people on board and to sort of identify the appropriate spaces. So just congratulations on that.
Oh, thank you.
Thank you. Manje? You can throw it.
Yeah, try
It would be
it.
nice to throw it.
Can I ask it in English, in Dutch?
Yeah, sure.
De sleutelfiguren voor de mannen in deze wijk. Je hebt buurtvaders die heel actief zijn. Zijn die benaderd?
Nee. So she is asking if there are some contact persons who are Schilderwijk fathers, and did we involve with them? No, unfortunately not, because we focused on a different group, and as I said, we didn't have enough time to change our approach. But in future project, we will definitely do that.
And we have considered approaching the buurtvathers, but it was a decision made in combination with the Mussen, especially because what they were saying, the buurtvathers in another part of the Hague, Transvaal, is very, very successful, but it's up to now not that successful in the Schilderswijk. So, but of course, buurtvaders could mean to be a very good approach to.
Ja, want ze hebben een belangrijke rol.
Ja, exactly.
En helemaal voor de jonge mannen die ouder worden.
They have a very important role, especially for younger men as well as for older men. Buurtvaders is a community project, some sort in which fathers. That's why we have mothers, but we also have fathers. Fathers approach young men about the way they live, the way they behave, about thinking about their future and such. Right?
Ja, klopt.
Okay.
Klopt, dankjewel.
Mag ik daarop aanvullen?
Yeah, of course. First you and then Manje.
Even daarop aanvullend. Wat ik zelf ook heb ervaren, want ik heb met moskeeën samengewerkt met bepaalde projecten. En het klopt inderdaad, mannen kunnen we heel erg moeilijk bereiken. Ik zeg het ook gelijk in het Nederlands, hoor, maar, zodat jullie het kunnen vertalen. Maar wat ik zelf merk is dus dat je echt wel sleutelpersonen in de moskee moet hebben, uit ervaring. En met name inderdaad die beeldvorming waar we het erover hebben. En met de tijd zie je dus echt wel dat er best wel mannen aankomen. Ik heb echt een volle zaal met 50 mannen binnen kunnen krijgen. Maar dat komt...
On what topic?
Over relatie, intimiteit, seksualiteit.
Leuk.
Maar samenwerking met de moskeeën zijn heel erg belangrijk. Je hebt in de moskeeën heb je dus mannen, hoe heet dat, bestuur en een vrouwenbestuur. En ik zou dus die voorzitter van de vrouwenbesturen zou ik dus eigenlijk bereiken. Zodat zij dan ook in gesprek kunnen gaan met het mannenbestuur.
Okay. I'll translate it first.
Yeah.
What the comment was, it is possible to work together with churches and mosques, and the lady gives an example about working together with mosques, in which there are two different bodies in the mosque. There's a women body. That's not very appropriate in the context of, but you know what I mean? A women body and a man body. And if you want to reach out to the man body, it would be maybe it's not a shortcut, but the best route is to do it via the women body. And the lady was giving an example in which she had 50 men in the room in the context of the mosque talking about intimacy and sexuality. So it is possible.
Yeah.
Great.
Thank you.
Thank you. A fascinating talk always. And as we've probably clearly found out, there are a lot of hidden voices that we need to find. Just reflecting back on both of your presentations, in the UK, we looked very much at certain groups, so maybe LGBTQ, and obviously in the Schilderswijk, the Schilderswijk mothers, etc. How do we widen the discussion? How do we include mothers in the UK? How do we include LGBTQ in the Netherlands? How do we kind of open it all out so we don't remain kind of segregated, we don't remain divided, in fact we become more inclusive?
In the last slide.
Can I? Yeah. Actually, as I said, in this project we focused on migrant women or migrant population, but actually we have other projects for LGBTQ, many projects, let's say, and specifically for LGBTQ asylum seekers and refugees, we have another approach which seems that works very well. We organize, for example, parties for them, and then we pay their transportation fees also for asylum seekers to go to the party. So it is a really nice party in a gay club, but then our public health services, people from public health services are there, and they also provide them with testing and vaccination, and it works great. So we have other projects for these groups. But yeah, what I said, we have to widen the conversation, indeed.
Would you also like to comment on that, Amanda?
Yeah, I was going to say I agree. And I think actually the answer is really simple, but it's also really complex. That the reason that we've had success where we have had, and it sounds like with SOA AIDS as well, is through existing connections and existing groups. And I think the actual answer to your question is that what we need to do is a much better job of engaging people who are already working with those groups. So for example, in the UK, we didn't do a very good job of engaging refugee women. We already know that there's groups supporting refugee women, so why are we not linking with them? The complexity, I think, is that oftentimes there's a capacity issue. Oftentimes there's a bit of resistance, particularly in the third sector of, well, if you work with us, you might take our funding. And I think a third complexity is that often the people that you're reaching out to as networks or potential connections are very uncomfortable talking about sexual health themselves. So they hear the word sexual health and they panic, let alone getting it to their thing. So I was actually going to put it in my presentation, but I didn't, that I think we actually reached out to 350 community organizations across Kent, Medway, Essex, West Sussex, East Sussex, and up in Essex. And, they were very, these weren't general information addresses. These were individuals. We got 7 responses, and only 2 were positive. And so I think that's the solution, but it's also the, it's also the problem.
Yeah. And maybe remember the very simple but very meaningful last slide of Maria. There are 3 important factors that needs to be used in an approach like this. That's time. You'll need lots of time to include every, because it would have been nice to include the LGBT community in Schilderswijk. Instead of a separate project, and it would also be very meaningful for the when it comes to sexual health and the emancipation of specific groups to include the LGBT community. But for that you need time, you need money, and you need cooperation and willingness of a bunch of organizations in the community sector, in the wider workforce, and in the healthcare sector. And I think it would have been we could have done it in the Schilderswijk. I'm looking at Mosca because she works at the Schilderswijk. I think it could have been done in the Schilderswijk, but if we only had time, yeah, and money, more money,
much more money,
much more money. Yeah.
We have a very last question which has come through online. We've actually got a few online, but we're going to just quickly answer this one. But as I said earlier, if we don't come back to your questions in the afternoon, we'll respond to them later. This is kind of a UK-specific question, so I'll read it and then answer it, and then we will be free for lunch. So the question is, did you find that older people were confident in accessing online booking and online sexual health services, for example, for STI testing? So I think I mentioned in my slides that in the UK, most sexual health services have gone online in many counties, many local authorities, because it's cheaper and easier. The answer is I don't know, because so much of what people came to talk to us about wasn't STI testing. I think I might have said in my slide, we only made maybe 13 or 14 referrals to STI testing. All of those people, we supported them with the registration process. So we got our computers out, registered them, got them all ready to go. So they were fine with it. But like I say, that was very, very, very rarely what they wanted to talk about. It was usually about the menopause or about relationships or about intimacy or other things. So it didn't actually come up a lot, even though it didn't really come up a lot. I would say the answer is probably not. with age.
But we have the same issue in the Netherlands, and I think the proper answer is we can't give a generalistic answer.
Yeah, exactly.
For example, it may very well help to reach out to asylum seekers because they all have a smartphone and use the smartphone quite extensively in Wi-Fi zones.
WhatsApp, yeah.
But not for example, for other homeless groups.
Yeah, no, that's right. That's right. And yeah, I think it varies. So, yeah. That was a great last question. Thank you all so much. I can see people are definitely ready for lunch. So just a quick message from the comms team who are working hard in the back. Actually, and I should just take a moment to say thank you so much to our comms team and to our AV team who are making all of this possible and making it look very seamless up here when it's probably not seamless back there. So thank you, everyone. But just to say, we're going to take an hour-long break. Well, just under an hour. We'll come back here at 12:45 p.m. UK time, 1:45 p.m. Dutch time, and all the presentations will be uploaded following the conference, again with subtitles. So if you've missed anything or really want to read them again, you'll be available and you can share them with your colleagues. For now, thank you, and we'll see you after lunch. Welcome back to everybody who's joined us online. We have a full agenda for this afternoon, and we don't have any breaks. So if you need a break and you're in the room, please feel free to get up and take one. And obviously, if you're joining us from home or the comfort of your office, we won't notice the difference. I also wanted to ask, though I don't know if I can get the slide back up. Can I get that? Is it possible? Sorry, I might be ruining your order. To get the Mentimeter slide back up, which shows the code, because Mani wanted to see if we would be able, yeah. So if you're online and want to, and or if you are in the audience and have your phone still, we just want to update the Mentimeter based on the rest of the presentations from this morning. So just a little warm-up activity before we get on with the afternoon's events. And I don't know how to make it show up. It seems to be something that happens magically. It does, it's magic. Oh, it's magic. Great. Yeah, the words. Yeah? Oh, do I have to? Oh, there we go. Look. So I didn't actually read what the words were this morning. So I will trust that Mani and Stephen will analyze later for differences. But it doesn't look like it's changing that much. So either people aren't listening or everyone has the same thoughts as they had this morning. No, it's not going to change? We're going to do it. Oh, there's another question. Yeah. Okay. 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 Sorry, for those of you who are online and didn't hear, there should be a second question coming up this afternoon. So the morning's question was, what does shift mean to you? And the second question is a more active question about how you can... Oh, here we go. What will you take away from today's conference? I'm so pleased that I prepared this in advance. What will you take away from today's conference? And then we are going to compare the Mentimeters from this morning to this afternoon a little bit later, or maybe online tomorrow. I know we still have sessions, so I presume if you want to at a later time and are really inspired by this afternoon sessions, you could go back onto the Mentimeters and re-answer both questions. That's what I'm hearing from my colleague in the front. Okay, I'll let you guys work on that when let's progress, because we're starting a little bit late from lunch anyway. This afternoon, we have 2 key sessions and a little bit of a final sort of debrief prepared for you. So first, what I will do is I will invite my colleagues up to talk about our third work package, which is around professional engagement in sexual health training. But they're busy talking in the front row, so I can't invite them up yet. I'll invite Luca and Kate up. Give them a warm round of applause.
Okay.
Oh, yeah.
Hello. Already? Yeah. Okay. Good afternoon. So we are Kate and Luca from Odyssey University College and App University of Applied Sciences and Arts in Antwerp.
Yeah, hello, welcome. Thanks very much for joining us. I'm just going to make a little note. I have a light sensitivity, so I'm wearing sunglasses. It's not because being on the stage is going to my head. Yeah, so Luca and I work in 2 different academic institutions in Flanders, and we were working on how to encourage and equip health and social care professionals to talk about sex. So you see from the title, Surmounting the Barriers, this is something we know is not necessarily easy. Why did we do this? Well, part of it, as you saw this morning, oh gosh, I've just pressed, there we go, sorry, learning the clicker. The model that we saw this morning presented by Monique and Stephen includes the enablement and training of people. So one of the things is trying to train and give resources to people working very widely in health and social care, and also to educate healthcare professionals and the wider workforce. So those were the 2 motivations for such a thing. And I think the question that ended Monique and Stephen's session this morning also said, how do you reach people? That's the question. So this is one of the things we struggled with and attempted to address. We also have a bit of an interactive thing. We used WooClap, not Mentimeter, so we have yet another code for you. So we're going to ask about 4 or 5 of these questions throughout our session. So there's a QR code, or you can go to wooclap.com and enter QCOGTI. What we want to do is get a little bit of a sense of who's here, so in the room, but also at home or in the office, so that we're going to try to make some links with the work that we developed. So what is your job title is the question. I'm going to see people still logging in before I go to the next slide. And feel free to interpret that question in any way you feel relevant. There's no right or wrong answer. All right, see some people still pointing at the screen. It's not working for you. I'm very sorry to hear that. I don't know if you can get some tech support from our colleagues sitting in front of you. Give it another little bit. Yeah.
We can do the magic switch.
Could we get, okay, brilliant.
Yeah.
Okay, wonderful. Okay, this is really lovely to see. So we're seeing here
researchers, psychologists, lecturers, something with sexual, but
nurse sexual health. It's moving a lot. We're trying to. Is a moving target here?
With coach,
nurse,
public health nurse,
program lead, strategic advisor. Okay. Yeah. I think our point is sort of made. We were trying to identify that in this project, we were trying to design training to reach a broad section of people who have many different job titles and who work in many different ways. So I think you see some of the things here represented are also the people that we managed to get in our focus groups and ask questions about their different needs. So I think it's wonderful to see here we have a lot of, obviously, health people, which makes a lot of sense, but a whole diversity, so ranging from people who are directly in contact to people maybe supporting other professions as educators, people defining policy for their own healthcare professionals or wider workforce as health and social care professionals. I'm going to move on. So in terms of who we targeted, the link we wanted to make here is that at the start of the project, we had, I think you've heard other people, my colleagues, say wider workforce this morning and healthcare professionals. But through the life of the project, we realized who fit into what group was not as clear as we'd anticipated. So a role that was considered a healthcare role in one country might be considered social care in another. We were also thinking about people who really specifically work with sexual health and populations and people who it could be part of their job in that holistic perspective that's come up a few times this morning. So what we did is we decided to switch the question around, and instead of trying to find these categories that didn't really fit, we instead made our training packages, we'll discuss later, targeted to a broad group of what we call health and social care professionals with content and skills training that could be adapted to the specific needs of the groups undergoing the training. So that was the solution that we came up with to try and address the, I was going to try to go back to the word cloud, but I'm scared it won't work, to try to address that diversity of groups there. And then the second question we want to ask you, so it's the same QR code, same thing, is how comfortable you are if you work with a 45+ population, integrating sexual health into your care, whatever that is. So you can answer in any way you see fit, and it's a scale. It's a numeric scale. So we'll give you, again, a little time to...
But I think you have to click first.
Do I have to click?
It activates the, the stuff, I think.
Nothing is
happening.
happening.
It activates the magic.
Is it working for you?
Yeah.
Okay, great. Okay.
Yeah, okay.
So there we go. Okay,
Yeah.
wonderful. So we had a scale here from very uncomfortable to very comfortable, and we see here and an option for student. Oh no, I think that's just everybody is students because it's WooClap, sorry. So how comfortable are you? So we'll let a few more results come in. We see that the tables are going up and down. Again, very free to answer however you wish.
So I feel like this is an audience that is already very comfortable in talking about sex, and that is also something we experienced during our training sessions, that we mostly attracted people that already have some kind of confidence or some self-efficacy when it comes to sexual health services and things like that.
Okay. So we'll just give that a little longer. If I see new things coming in. Okay, so that was 36 people. 37. All right. So this was about comfort. And one of the things we identified this morning is also other obstacles, barriers. So the next question I'm going to ask is, how often do you integrate it then? So there's one thing about being comfortable, but another thing about can you then do it? How often does it actually get integrated into your care? And, okay, wonderful, thank you. So we have a wider range here. Of course, we can't match it up to see the people who were comfortable or not, but this is one of the things that we wanted to address also in our training, is that we might have people who felt comfortable, but we're looking for ways that they could actually take opportunities and integrate it. And then there were also people who might be uncomfortable, and so we need to address that as well. So that was just, these are just two questions we wanted to ask you to get you thinking a little bit more interactive after lunch, and engaged, and see that it is, when you're trying to make a very general training program, but there's just a bit of noise in the room.
Yes, what is happening? It's like...
which we're just trying to talk through.
Yes.
So the two different things, and also just to acknowledge that feeling comfortable with something doesn't always give you the chance, and vice versa. Okay, so we're going to continue with the presentation now.
You have to.
Is it going to work now?
It's the same question.
Yeah, so this is the same question. So I need to just move to the next slides. Wonderful, thank you very much. Okay, so this is just trying to give you a little bit of a sense of the process we went through when we were developing the course. We, courses, the training packages. We held focus groups, so 9 different focus groups that were held in the UK and in Belgium, with a wide group of health and social care professionals from different backgrounds. And we identified these top 5 issues as what the needs were. Now, what's interesting is the presentations we saw this morning that Monique and Stephen identified about the 4 axes of the SHIFT project, about knowledge, awareness, stigma, and so forth, were also kind of reflected in what the health and social care professionals identified as their training needs. The first one we're going to come to later, in the next slide. But what about knowledge? Knowledge is very broad, and part of it was a general knowledge, Gesundheit, as has already been identified, a base of sexual health across the life course. So how does sexual health, physiology, aging change? But there was also a request for some specific information about special groups, particularly in Flanders, there was an identification of more knowledge about LGBTI plus groups, and also certain risk groups. So we try to reflect that, you'll see in the training we did. Communication and self-efficacy is linked also to the first one. It was quite difficult. These things really fed into each other. But another thing that came out was the professional role. So did sexual health seem to fit obviously into my professional role, or was this something that we hadn't traditionally addressed? A lot of the health and social care professions have a very holistic model, but then identified that sexual health was a part that wasn't often addressed. So this was one of the things that we tried to pick up on. And then another thing that came out of the focus groups was really the form and delivery of the training. Now, our focus groups were held largely at the beginning of the COVID pandemic, so it also became very clear that we had to be very flexible in terms of how we're going to reach people, and Luca is going to talk a little bit about that more later. But it was very clear that professionals have different needs in terms of how it would be possible to follow training. So we try to incorporate a lot of these things in what we produced. And this slide is just to talk about the connection between that first and third point that I talked about, that when we analyze the data and what people said in the focus groups, that their awareness and attitude about whether sexual health could be included in their role or not was often linked to their sense of confidence and self-efficacy, but then they often identified that they needed more knowledge about it to feel more confident. So there was a sort of feedback cycle, and the same thing about the communication techniques, that people felt that they were good communicators, they could raise topics, but maybe they needed to know more in order to raise topics about sexual health, so they had to be aware of it, or aware that there was a need in their patient group. So the reason we ended up with this figure is because when we looked at statements people made, those concepts were often made together. So that was the interconnectedness of those aspects. So I'm going to pass over to my colleague Luca now, who's going to talk more about the development process.
Thank you, Kate. So how did we go about developing the training? So we had the needs of professionals from the focus groups, but of course we have an amazing Shift partnership and all of these expertise and people working with the age group, but also having a lot of knowledge and experiences talking about sexual health. So we also used their input, of course, and we looked at the literature and looked at existing training material on sexual health and training healthcare providers. Next, we started out with formulating different learning outcomes and then grouped them together in different packages. Those different packages, we got feedback from experts, and today there are 2 experts here in the room who gave feedback. So Svenja and Els, thanks again for your expertise. So with this feedback, we produced 4 final training modules. And the 4 training modules we produced was Start to Shift, Assess and Communicate, Embrace Difference, and Reduce Risk. 2 of those training packages, so Start to Shift and Assess and Communicate, were actually about the fact that people wanted to know more about how we engage the 45+ population on sexual health and how we start the conversation proactively. Then the other 2 were more about knowledge and skills, because as Kate said, professionals really had the feeling that they didn't have enough knowledge or enough skills on sexual health and on sexual health education. All of the modules are there to raise awareness, but also get professionals more confident and give them the feeling that they actually can do something in sexual health care. So I will briefly explain each of the modules because we, as a Shift partnership thing, they're very exciting. So after today, we hope even more professionals will come and do the trainings. So the first more general module is the Start to Shift module. It's an e-learning module, and we address the impact of aging on sexual health. So for example, as Kate said, is the body is changing as we get older, but there's also a difference between female and male. And so we give some insight into that, and also the basics of sexual health and sexual well-being. We already introduced a method here, the one-to-one method. In Dutch, it's the onder vier ogen method from Sensoa. So there are videos, interactive, like exercises to get someone, professionals, to learn about sexual health for this target group. But it's asynchronous, so an e-learning that is very accessible, so professionals can do it in one go, or they can divide it up and take as long as they need. What was also very important for health and social care professionals was that they wanted information on signposting. So we put in a lot of information on regional signposting opportunities. For example, we have signposting for the Netherlands, for Belgium, and for the UK specifically, so they can download it there. Assess and communicate, as the title says, is about risk assessment, but mostly about communicating. How do I start a conversation, and how do we put the eye-to-eye method into practice? So there's also a bit of role-playing, not like in the bedroom role-playing, but role-playing like mimicking the client and professional relationship, and how do I start a conversation, or we give a couple of phrases that might be easy to use. And for a lot of professionals, it feels easier if they have like one phrase to start up the conversation, or a method to come to the conversation. Embrace Difference, a module on diversity and inclusivity, yes. I saw the word pop up a couple of times in the Mentimeter, so I'm very glad about that. But it's not only about ethnic or cultural backgrounds, but also about LGBTQ+, about including people with disability. And there are a lot of self-reflection exercises in this module to really become aware of your own frame of reference. Like, how do I look at other people, or maybe people with a different background, or with a different gender, a different sexual orientation, types like that. The last one, Reduce Risk, is quite a lot of theory, a little bit about STIs, but mostly about transgressive behavior and how do we address certain topics, or where is the line between my professional role and the privacy of clients or patients. Also, the impact of chronic diseases. We already saw that more people are getting older and there are more chronic diseases, so getting professionals to become aware of the fact that this chronic disease also has an impact, and every chronic disease has a different impact on sexual health, is quite important. So we use case studies that we made for the trainers to use, but we also invite the professionals themselves to give us a case they experienced during their own job or in their profession. So most of, or a lot of you are working in healthcare and know that there is a lot of pressure on nurses, on doctors, on practitioners, whoever works with patients or clients or with the target group. And of course, we had the COVID pandemic, a lot of fun, but most of the time, especially today, when we talked about COVID, it's about restrictions and things we couldn't do. But the positive thing in this project was, because there was COVID, we had to be flexible. We had to think about how can we make these modules as accessible as possible for professionals. And that's why we, when we piloted all of the modules, we kind of experimented with doing things online, doing things face-to-face, having an e-learning, having trainings in different lengths. So for example, we did a training for 3 hours, and then other partners said, okay, we're going to divide the same training into 3 different time blocks and do it for 3 weeks, and then just one hour each. And we also want to encourage other or existing educational programs to integrate these modules into their educational program. We did in Odyssey and in Antwerp already for the nurses' education, but also occupational therapy. And we can see that also students are interested, so that's a plus. But what if you want to get trained? So please visit our virtual learning environment. There you can start off with the e-learning module. You can find contact information about all of the organizations linked to the SHIFT project that are doing the trainings for professionals. But if you are an educator or you are someone who wants to give the training, you can also download all of the information freely. It consists of a PowerPoint presentation and a training guide for the trainer, so it's really easy to access. You can also use whatever you want. You can combine different modules. You can switch the order around. So we hope that a lot of educators also have some fun with it. I don't know. They're all in Dutch and in English, so there is information on the UK, but there's also information on the Netherlands, about Belgium. And they're all piloted, so they're SHIFT approved. We wanted to show you today a couple of exercises we do in the modules. So the first one is we get professionals to think about their personal barriers. So I think we saw a lot of them today already, but it would be interesting if you can write some down.
Yeah, so we're gonna, so we've sort of done the major part of the presentation, but we thought it might be interesting for you to sample a little bit of the kind of questions that people who did the course themselves had to answer. So this was the first reflective exercise. And as you can see other people's answers here, also when you do the online course, the people who take the course can see answers that other people have given anonymously. So we see here, think of your own professional barriers.
I recognize a lot of the barriers that we also get online. And that's also the interesting part, like online in the e-learning, we ask professionals to think about their own barriers, but at the same time, they can see the barriers that other social and healthcare providers put in the system. So then they can reflect on maybe something is new to them, or a barrier that they didn't think about, or maybe it's also just you recognize the same barriers as you have in your practice.
So it's sort of, give a sense of you're not alone. I think that's the other thing.
You're not alone.
I think it's interesting the word time is in the middle and in large letters and red.
Yeah.
So
and
that's
knowledge as well.
Knowledge as well. So, and I think the other thing is this is done at the beginning of the online module to get people also to think about anything that we do near, would it help with my barrier, help overcome it, okay?
And then when reflecting upon all this, we also give them some quotes. So this morning we saw a couple of quotes of Dr. Hinckliffe. And we also show real quotes to the professionals to just get them thinking, to raise that awareness. This is typically someone in her 50s. She says, it's not easy talking about your sexual health with someone who is much younger than you. So that's also important for maybe a healthcare provider to realize. A man that says, I want to get tested for STIs, but actually I feel a bit embarrassed to ask the doctor or the practitioner, especially at my age. And then someone who said, I'm a heart patient. It has an impact on my relationships and intimacy, but I have the feeling that I can't talk about that with my healthcare providers. So these are examples of how to gain insight and to raise that awareness about what is happening in our healthcare system. This is...
I'll introduce... Is that okay?
Yeah. Okay.
So that was from the Start to Shift module. So that was something that people do on their own, the first one that we saw. And this comes from the Assess and Communicate module. And this illustration comes out of a book that actually from Else, who's sitting with us today, and her colleague developed. And Luca and I, when we were preparing this presentation, we decided that we were going to do it a bit of a different way, because in the Assess and Communicate module, people are forming a group. By the time they look at this picture, they've already met each other, and we've created a bit of a safe space to talk about it. That's obviously not the case here today, and also for the people who are online at home. So that's why I just wanted to draw your attention to that. When we first ask, we're going to get you to look at these pictures, and then instead of filling in a Mentimeter, it's going to be like in your own head, what we're going to do.
So we won't force you to talk about it, but we will ask you some questions. Like think about what do you read in this illustration? What do you see? What kind of feelings does it evoke? And then we use this illustration as a starting point to start a discussion on what do you see? Are you aware of what links you make in your head when you're looking to this picture? And we did notice that for a lot of professionals, they had a totally different view on what they were looking at, and sometimes we had discussions on terminology, and then everyone wanted to be right, and so that's why we won't be discussing today, because I don't feel it's a safe space or environment this way to talk about it. Then after this discussion, we draw them in deeper by giving them some quotes or statements to talk about. For example, is it disruptive when an older man acts like a woman, or vice versa? Or respect for adults includes attention and support choices in their appearance, their care, and their clothing. People of a certain age are allowed to be intimate in public, other ages are not. Some of these statements evoke more discussion than others. It's also depending on who is in the session. So if you have more, if there are a lot of different backgrounds or a lot of different professions in the group, then you have a totally different discussion than when it's all nurses or all GPs or all. So if you are considering of giving the training, it's best to mix it up a bit. Then you have more interesting conversations. So what we've learned is that actually we had positive feedback from professionals who took the modules, the training programs. They really liked our videos and the interactive part, so we are very proud that we can present that today. What we didn't expect, especially in Flanders, that they wanted to have the role play to have a more prominent role in the different modules. So we will be integrating all of this feedback in an updated version of all of the training guides and presentations. But yeah, that kind of surprised me that they wanted more role play, because we are teachers, and normally students, when we ask them to role play, they're like, that's okay, but not me, not me. But professionals, they do like to practice and participate in the module. So what you should take home, I know it's the question that Mani asked, but what you should take home is that...
Suggest, not should, it's a suggestion.
Yeah, I'm a bit more strict than Kate. They're like, no, but for the trainings themselves, so it's better if it would be integrated. So if you are an educator, please integrate it into your program, but also in continuing professional education. It would be very interesting and would be another way to get the communication on sexual health a bit further. It should be easy to access, so do the online stuff, do it face-to-face, use the e-learning. It should be tailored to the existing educational programs. And as we said, it should be a safe environment where everyone feels they can talk about whatever their opinion is on sexual health, especially for this target group. And it shouldn't only be based on knowledge, but also on the participation, interactive parts, and really practice communicating on sexual health. So I really want to thank all of my SHIFT colleagues, the experts here sitting in the room, because we had a lot of fun, also a lot of work, to be honest. But I had a good time. I don't know, Kate, we were talking about missing each other after the project. I don't know if anyone here in the room has questions or comments on the
the chat.
things.
I don't know if there's anything. Is it there?
In the chat, but they need 30 seconds, I hear.
Okay.
So,
Do you want to do the room and all?
Yes, a question. Here's the box, here's the box.
Hello, so I just wondered if there was any insight or any opinion from yourselves about how we get the workforce and professionals engaged in the training so people understand that it's relevant to them, so they come along. Because I think at the moment there's a gap. We've got this resource, which is fantastic, but in my humble opinion, we haven't got the piece that says this is how we engage people to do it. And I just wondered if you had any reflections on that.
Yeah, so it's difficult to know afterwards if they actually are doing it in practice. I think this is a first step. There should be a SHIFT 2.0 maybe. But what we also noticed was professionals that are already interested in the topic, they come to the training. So now we need to do the magic step of getting people that aren't that interested or less comfortable talking about sexual health to get them to do the training. So what we were thinking about was when we do like often there is this conference or maybe a day that we invite a couple of speakers at the university or somewhere else, that we try to put in one section on one of the SHIFT trainings or something, so that they are actually coming for something else, maybe in terms of mental health or holistic health or holistic care, and that we integrate it. Like one of the topics is sexual health, and then maybe step by step, professionals will get more interested. But I think a big step is if we integrate it in like the bachelor's degree and the master's, and get like a lot of different healthcare professionals together to do the modules. So for example, a doctor in training, but also an occupational therapist or a physiotherapist, and get them all together and start talking about sexual health.
Yeah, I think it's interesting because it's the same strategy that we heard this morning about reaching people. It's like sort of, oh, we'll come along as a health check and then we'll integrate it. And it's a similar thing. I think in the UK, Gesundheit, in one of your trusts, you did try to integrate it into an existing permanent training that, or continuing professional education that was required for people. We've tried an Odyssey. We have a mentorship for nurses. We've integrated a day on difficult conversations. How do you support your students to have a difficult conversation? Oh, also one about sex and sexual health. So trying to come up at it as integrated, and I think coming back to the message that a lot of health and social care professions have of looking at the patient-centered care and saying, well, if we're patient-centered, this is part of the patient. And I think that ties in really nicely with the notion of the rights and the charter that we heard from Dr. Hinchcliffe this morning, that if we truly think that, we're going to start from their perspective, then we have to do that. So I think you're absolutely right that we identified through this some training materials. You have to get the people to it. We also have different, I think there's a sort of synergy at the moment. For instance, in Flanders, there's a cancer charity called Kom op tegen kanker, and they just did a study and released a study on that cancer patients would like to talk about sexual health more. And that's a group, I'm an oncology nurse by background, and people say, oh, it's the last thing people are thinking about when they get a cancer diagnosis. So, well, no, actually, 450 people said they really wish someone had spoken to them about it right at the beginning and not just about freezing their eggs. So I think it's trying to raise that awareness and all these different movements coming together and then saying, look, and there are materials easily accessible. You don't have to develop a whole new program. And I think the key message is you don't have to become an expert on it to bring it up. If you know you can signpost, if you can ask a question. And I think so the one-to-one model that we use from SENSOA also really highlights that as well, that it's trying to get people to broach a topic and then say, okay, this is now raised an issue. We're going to help you through these other services, and it's not my responsibility. I'm just going to ask, it's a black screen.
Can I read it?
Okay, that means no one has a question. People at home or in the office.
You can
please
ask us questions, please.
Okay.
No, I don't know if someone else has a
comment or question
or question or something interesting about healthcare professionals and sexual health. No? Then it's okay.
It was just so clearly explained.
Another question.
So is there a particular profession that you see that from this has maybe done it more? Have they been trailblazers? Have they been more engaged than any other group? Or is there anything from the evidence you say that group over there have really nailed this or seem to be more engaged or it seems to be a better fit? So was there
it was very depending on the shift partner that conducted the trainings. So if a shift partner had a big network in with nurses, with sexual health nurses, then we saw that there were a lot of nurses going through the training. So and also in our connections, like there were a lot of, I think, nurses, psychologists, but actually in Belgium especially, most of the people that came to the trainings already had some kind of interest or link to sexual health. And actually that was a pity. But we did force the e-learning on nursing students.
We invited nursing students to take part in the e-learning.
She wasn't there, she doesn't know. Of course, no, but we invited them, and also occupational therapy students. And yeah, actually they don't mind doing the courses. But yeah, if you don't provide them, I think they will choose other things. Like if you make it part of their education, they think it's normal. And that's a part of it, also normalizing. And I do think that the e-learning, because we also saw that in the e-learning there were a lot more people taking the course. That's easier to access. You can do it in your own time. You don't need to schedule it. You don't need to be at a certain place at a certain time. And we did see a lot more people taking Start to Shift course than the other modules. So maybe that's also a way to go. Question.
Yeah. So Kez Spellman says there's a risk that professionals feel the need to be able to answer knowledgeably about everything. Were there were opportunities for two-way learning established, thinking that it is important when working with people and diversity. So of course we're interpreting your question, Kez. I think one of the messages even in the specialist modules was, here is some information to get you started, but you are not responsible for knowing everything. Especially in the diversity module, the Embrace Difference, it was like there are many different kinds of diversity, and what's your starting point and what are you letting your client or your patient tell you? So to learn from them, so I don't know if that's the two-way as well, but also to respect the knowledge and starting point of the person in front of you. I don't know if you want
and
to
also
that.
If it was for example, if it was about knowledge, we also not really wanted them, for example, to get all of the words right or know all of the definitions, but more where can you find more specific information together with your patient or with your client on that specific topic. So also, for example, if you have clients with a different cultural background or they talk another language, you can use this website, you can use that tool to use during your consult or during your care with a client or a patient. So the knowledge isn't that really we offered a lot of theoretical material. It's more like where can you go to get certain information that you will maybe need for some people or some different groups.
Okay.
It says 10 minutes left. I don't know if it's...
But I just wanted to one of the things was in the previous question that Kez asked, that the whole notion that you have to be knowledgeable about everything is something we wanted to make clear is not the case, because you can't know everything about everything. But if you never ask a question because you're scared, then that person never has a chance to present that as an issue. So there was that.
And also telling professionals, it's fine if you have to go and look for information together. But a client or a patient just wants a bit of help, and you can direct them to that help. And but yeah, most of the healthcare professionals feel like this is my area of expertise, and I need to know everything. And yeah, that's not true. So you can go if you want to, Mani.
Thanks, Luca. Thanks, Kate. I just wanted to reiterate what you've been saying about the fact that the training isn't supposed to make experts out of people. It is supposed to help open those conversations, find out where we can talk about things, where you can kind of look during your consultation, which may be on, as we've discussed, something completely apparently not relevant, but probably where sex is relevant. And certainly when I delivered some of the training as technically a sexual health professional, there's so much that you learn from the audience. There's so much that you gain from that training. So for me, delivering the training, as a trainer, I learnt so much. I kind of thought, oh, I didn't think of that, or you know, someone else has thought of that. I really had no idea that was important. So I think training is both ways. Both as a trainer, I can deliver stuff, past knowledge, past experience, but I will also receive that knowledge and experience. And for me, it's been really eye-opening participating in the shift training and developing it.
I think, especially in the in-person training and the face-to-face training, that was a fact. I did feel like the online training, we had a bit less of exchanging information between the participants.
You mean when we delivered the live training online?
Yeah, then it was a bit less, not that they didn't get the conversation started or something, but that's the upside on the face-to-face trainings, is that you can really practice and people are more at ease, and someone says, but I know a good website on this, or did you see that Instagram post on blah, 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 blah. Oh, that's very interesting. And yeah, that's also part of the training, like getting to know other professions and what they know about sexual health. So
yeah, I think, yes, I mean, just trying to make the distinction between the asynchronous module where people learn themselves online and the fact that we delivered some of the live modules online. And there's a couple of people here who were part of the first one we tried to pilot. And it was interesting because we were sort of a year and a half into the pandemic at that point, but we still had a lot of technical difficulties, which made discussion difficult sometimes because people couldn't sort of speak or hear what was being said. So it's one of those things I feel like, I think that technology is going to get better and better. And then I feel like maybe some of the differences we had, I mean, of course, there's always a difference when you can see someone's body language and respond together as a group. But I sort of am hopeful that if that's a way that we can reach more people, that when the technology gets even better, that we'll be able to continue to do that.
Of course.
Yeah.
So now everyone's going to the website, to the Moodle.
Yeah.
Downloading the training guide.
Well, they might want to wait to download the training guides until December when the most recent
but you can already if you're
really keen.
If you're really keen on doing it and implementing it.
Yeah. There's just a question here that's specifically directed to our Dutch colleagues. So it says, do you also know whether the POH support staff of the general practitioners in the Netherlands also focus questions about sexuality, and do they take your training? So I don't know POH.
Yeah.
Steunen. It's a GP assistant.
Okay, so that's what you talked about, yeah.
So we had a lot of GP assistants do the training.
It's the nurse.
Okay. And they were people you were trying to target in your training?
Maybe she needs to.
Okay. Okay, so that leads very nicely to, so just for the people at home, Tatiana was just answering that they had tried to target this group in their outreach, and then the person who's going to ask a question now is actually a POH. So you possibly can ask a question and answer the question that was online, yeah.
Well, we did try to get the POH and the nurse assistant, but somehow it didn't work. They didn't have time, or over asked, I think.
Yeah. And I also do feel that after the pandemic, like a lot of nurses and doctors needed some like time to breathe.
That's
and we with our shift program and sexual health, and they were, I think,
just
a bit tired, and
work.
that's not the first thing they wanted to work on. I think that's, but the trainings are still there, and all of the partners can still provide the trainings. So in the future, people will get trained, and also because of COVID, I feel that there is less. A lot of people won't really want to come over to a certain place or to do a training. I think they don't.
We did it online. We first offered training face-to-face. That didn't work, so we said we do online, and then online it was only maybe 8 or 10, so it's quite well.
We had the same difficulties, so.
Timing is everything, eh?
Yeah, I think we should keep bringing it up and keep advertising, like, you can do trainings, and then hopefully there is some, I don't know if you say mouth to mouth, no.
Yeah, word of mouth.
Word of mouth.
But I'd just like to add that when you start training people, it's very good to start with themselves. How were you brought up? What's your background? How do you look at sexuality? Because you can add all information and things to learn, but if you have your own perspective, it's good to be aware of that. So
and
that's how we started
address
the training.
In the Embrace Difference module. Like we invite them first to look at themselves and maybe introduce themselves. Who are you? What are you doing? What's your background? And then start from there.
Yeah, that's
and that's also a beginning. If you are in a group and it's face-to-face, then that's the first thing. They learn how to talk about sexual health with other people from different backgrounds. So that's why we said try to mix it up. Like different people, different backgrounds, maybe different ages as well.
Okay, so I have one more thank you very much, Marieke, and I think that's something that we try to integrate into the different learning, always starting from who you are. Also because of the diversity of people we expected to take the classes, so personally and professionally. So I'm allowed to state this is more a statement that we're going to share with you.
Good, because we only have 1 minute.
And we have to wrap up. So Boutiana El Massoudi, thank you very much for your input. You say you're a last year nursing student from Artezes Plantain, AP University College, who loved this event very much. I did take the e-learning as well, and I do hope there's going to be training modules for students specifically. I feel like the modules now are more specific for people who are already have this kind of contact. Is this going to be any in the future? So I think that's a lovely comment.
I will do that for you, and thank you for your comments.
Yeah, so I think it's adapting for the people who were present in the course, and we will take your comments into consideration, Boutiana. So thank you very much, and we will wrap up now.
And we will stop. Did I say it?
All right, thank you. Am I on? Yep. Thank you so much to Kate and Luca. And my my next contestant, no, I'll just pass it over to Dr. Ian Tyndall, who's ready and waiting to go.
Thank you. Thanks, Amanda. That's a very tough double act to follow, Luca and Kate, and I really enjoyed that. It was really interesting. But I think it's been a fascinating day overall. I think we've learned a huge amount of information. And I think for the purpose of what I'm going to talk about today in terms of evaluation is I hope you got a sense of the scale and breadth of the SHIFT project, what our ambitions are, what we hope for, what our goals are. And you can see that it's something that has grown and has mushroomed over time. And we're going to look at some of the successes and possibly some of the challenges that we faced over the last few years. So I'm going to talk through and try and interconnect and bring everything together that Munyi and Stephen were talking about this morning, that Tatiana and Amanda were talking about, and also that Luca and Kate were just talking about there today. So I'll just bring it all together and see how the SHIFT project works as a whole. So I'm going to talk as well about our data strategy and methods. So my name is Dr. Ian Tyndall. I'm from the University of Chichester. So we are the evaluation partners in the project. And I'm just the public face here today of a large team that are working on, and I'll mention those towards the end. So it's a lot of people that have been working on this, but we are the evaluation of the data that has come in from the partners, from Luca and Kate, from Munyi and Stephen, from Tony and Stuart, and from Amanda and so on. So it's a lot of people's work coming in here that we're looking at and we're trying to evaluate and try to make sense of it. And I think for this one, it's nice for us because normally at conferences we have to try and almost compete to who's going to present the most complex data, who's going to present the most complex model that no one can really understand. And that's not something I think that is conducive to people coming home with a take-home message. Well, what did we actually find out today? So just to be rest assured that what we're going to present is very easily digestible data that will make sense to everyone. So we're just going to talk through each of the individual data strategy collection and methods as we go through each individual module. So I think when you mentioned this morning the co-creation and the co-design, and it was also mentioned by Tatiana and also mentioned by Luca, and I think it's really, really important. So to show that we did not assume in this module, we didn't assume that, okay, we've got lots of health experts here. We've got a doctor in Dr. Munyi Tung, we've got public health experts in Tony and Stuart, we've got charity experts in Metro, so we already know the answers. We didn't already know the answers when we put in the application form. We had ideas about what we'd like to explore. And with the co-creation process, we said, okay, what's already known out there in literature? So we had to conduct a literature review. What do we know as health professionals? What do we know as academic partners? Well, what do we know as charity workers? What do we know as county councils and public health officers? But more importantly as well, what do the people want? So who are we trying to connect to? Who are we going to talk to? Who are these interventions going to be for? What is a model going to do? And who is the model for? So importantly, we talked to people, we got feedback from them, and then that directed our further modifications and adaptations of the model. And then we fed the data into what became the model, and then we've evaluated that into different work packages that you've heard about today, work packages 1, 2, and 3. So it's always been refined, but importantly, it's been refined by the people we're targeting, people over the age of 45, people who are disadvantaged, people who are hard to reach, and also the health professionals as well. So it's been refined by all our key stakeholders as well as ourselves. So just looking at the types of data that we present and the types of methods that we use to analyze the data. So there's a lot of frequency data, and you'll have seen that with, for example, with Amanda's presentation earlier on when she was talking about reaching 3,000 people with her outreach work with Metro Charity, and also we looked at with Luca and Katie the kind of numbers that were taking part in those trainings as well for work package 3. So we've seen a lot of data. That's really important for the kind of work we do. Who are we reaching? How many are we reaching? And are we reaching our intended targets? And we'll also be talking about head counts, people who are there. We'll be looking at survey data as well, like who are we reaching, how many, and is it the kinds of people that we want to reach? We'll also be talking about observation forms as well, and the point of it. We'll be also talking about a technique called Think Aloud, where we ask people to look at the SHIFT website and see, can they explain what's on it? Do they know where to find things? Just because we think it's there and we think it's easy to find, does that person who we want to use it actually think it's easy to use. And we're just looking at all this feeds naturally into the bottom of the pyramid. You see is what the 4 key words that pretty much everyone has talked to say earlier on. What is there any increase in knowledge? Is there going to be any increase in awareness in people over the age of 45 and in the hard to reach groups? And is there any increase in access that we're showing them that these kinds of services are available and where are they? And also, can we reduce stigma, which is always, as Monique said as well, and as Lucas said, it's tricky to reduce that. So we're also looking at the work package 3, which Luca and Kate have gone through in fantastic detail there. And just looking at the ways that we've analysed that with our frequencies, the observations, the kinds of health professionals and the wider workforce who are doing it. And we also look at the interviews that we've carried out with people who've conducted the interviews, and also some of the people who've taken part. So we're getting the feedback from the people who are doing it, but also the people who are leading as well. So we get a broad picture of what's going on with that. I think it's important just to bring back, because we've seen a lot today, but just to the needs analysis. So this is just a picture of all of us in Metro, I think in November 2019, before the COVID pandemic, and when we sat down and say, what do we need? What do our clients need across these broad work packages that we were talking about for the over 45s general population, for the harder to reach populations, as Amanda and Tatiana were talking about, but also our frequencies with the work package 3. Sorry, people, professionals. So we spent a lot of time. It's not easy to do that. It just took a lot of time. There was a lot of kind of stress in this at the moment as well, because we had lots of ideas. We had so many ambitions for the project, a lot of strong opinions. And this was really important work, but it took time. It took about, say, a year and a half for us to really get going on the project before we all agreed on it. At times it got fractured, but we all, as you see today, we actually do all love each other, really. But the needs analysis was really important because it feeds into the model and makes sense of how we evaluated, because then that led into the knowledge, access, awareness, and stigma. And with the over 45s, we started off with surveys. We wanted to, okay, what do people need? What do they know about sexual health? What are their needs, desires? What are their fears? What's their lack of knowledge? Do they really experience stigma and shame, or is that something that we assume? So we asked all of these questions in surveys, and we targeted people across the continent. We had 614 participants for work package 1, the general over 45 population, and we reached 163 of the much harder to reach populations. And that was reversed for the interviews. So we conducted some intense focus groups and one-to-one interviews after the survey to get more richer and deeper insight into what's really going on with these people and how can we help them to develop our model and see what the real needs are. And there's some great work by Tony and Stuart and their team, and Metro Charity as well. We got 99 participants, which is an excellent figure really for a really hard to reach population with work package 2, which includes migrants, asylum seekers, includes the LGBT community, people with HIV and so on, as Amanda was talking about earlier. So it's quite a broad group. So we were really pleased with that. I mean, 26 participants in work package 1, but that we got some really rich qualitative data. So we pooled all of that together to help us form the model and which everybody fed into, all the partners. So just things like reducing stigma, how do we improve access? These were some of the things that came up in the surveys, interviews, but also some of our understanding of current best practice in the area from our own knowledge from working with these populations. And how do we raise awareness? What kind of media do we use? What kind of posters would work best? What kind of technology should we be using? Should it be only for doctors and nurses, or should we be empowering the wider workforce in general, people who work in charities and so on? So all this information kind of fed into the beginnings of the model. An important step for us also as well, we just had a paper published there a couple of months ago in one of our top journals in the field, the International Journal of Sexual Health. So this was a scoping review of the data. So a scoping review of studies that had actually been carried out, that have actually carried out interventions with the older age population to do with sexual health and well-being. And I think one reason why I have to say it's important, because even with the reviews, we got back reviewers saying there should be lots of these studies. Surely there's been lots done. And it shows us that there's a lot of bias out there already. We surveyed over 7,000 studies, and then we reviewed them. We got them down to there's only 9 studies that had carried out an actual intervention which had quantitative data, so numbers data to show there's an effect of from pre to post in terms of whether that intervention was effective at all for that population. And 7 of those 9 were in HIV, and that's likely because it's the most funded area within sexual transmitted infections. But it wasn't all to do with sexually transmitted infections. But in fact, we found only 9 studies across the world, this was the global literature search, on sexual health interventions for older age. This feeds exactly into what we're doing with SHIFT and why SHIFT is needed. There's not much known out there, and it's extremely limited to one particular sexually transmitted infection or particular condition that people live with. So we published that, and so it shows that, but the reviewers were saying there must be more out there, but there wasn't. And this is something that we really have to emphasize with our why SHIFT is needed. So when you, as I was already referred to the model, and also Luca Aldbert and Kate presented a nice chunk of it that was really relevant to our work package 3, thought was really neat. So this is our COM-B model. COM-B stands for capability, opportunity, and motivation, and the B stands for behavior. So it was developed by Susan Mickey and Robert West in University College London, and it's a way of assessing behavior change over time, and including your intentions, your attitudes, your beliefs as well, but importantly, changing behavior. That's what we want to do with SHIFT. We want to change people's behavior so that they can access, and they will access. We want to change their knowledge, and we want to change their attitudes and awareness. All that is behavioural changes, and hopefully reducing stigma with it. So it's been covered well already by Monique and Stephen. So just remember there. This is important. This is what we developed. And said it took us a long time to develop this. This is a version of our logic model. And the reason why it's important, it forms the basis of every evaluation activity that we have done since. So it's very, how do we get to the last column of the knowledge, awareness, stigma, and access, is we're doing things like a Think Aloud study. We're doing things like work package trainings, and which we already mentioned. We're doing things like the outreach activity that Amanda and Tatiana have mentioned. So these are the things that we need to do to meet the figures that we had in the application form, such as, for example, work package 3, we intended, as Luke and Kate said, we intended to reach 700 professionals, and we have almost reached that number. We're really pleased with that. We're hoping to see an increase in number of tests taken by 20% in the over 45s. That's an ambitious figure, but we're hopefully we're seeing getting closer to that. We're hoping to reach 37,000 people over the course of the pilot model, but we have, as certainly Tatiana mentioned, there's been challenges with rolling out the pilot models due to COVID, but we are on the way to meeting those targets. So work packages 1 and 2, so we talk about these first, and they're kind of together. The work package 2 is just a more tailored version to people like migrants and homelessness, people with drug addictions and so on, all the various different conditions. But it's usually a sign of the deprivation. So we're just looking at the demographics of the outreach. So Amanda mentioned earlier on all the different activities that have been done and reaching 3,000 people. These, the 3 that we have on the map here were the 3 that Amanda's given us data for. So there wasn't data for everyone. As Amanda said, some events were not as suitable for collecting data. Some people were not as willing to talk, and so on. But these are the 3 kind of major events that Amanda's given us the data for. So what we're seeing with these outreach, like when Amanda going out talking about SHIFT, and also with her Metro colleagues talking about SHIFT, going through the model, and also just getting to talk about their sexual health needs and so on. So with the gender breakdown, you can see that male is 33% and female is 61%. That's pretty good for this kind of outreach work and the kinds of people that go to this. But Amanda did mention as well that you do get good figures of males at Pride events and so on. But you can see with the age group, we are reaching that age. So over 76% are in the 45 to 64 bracket. And we also have a good number over 65, which is really positive too, which is 14.3%. So we have really good numbers in our targeted demographic area. We've also got a wide range of relationship status types, which is important, from the single and the married to widowed people as well. We've also got sexual orientation, a good range there from gay, lesbian, bisexual, heterosexual. So we have a good range of the people that we're hoping to target with that. And we got good insight into what the current level of sexual activity is and how frequent it is. So what the people are telling us anyway, and they're telling Amanda and Metro colleagues at these events, is that they came out of curiosity. They're walking up to the mobile bus and out of curiosity in the stand, and plus with that kind of character, you've seen the charisma that Amanda has, and it is that warm openness that Metro people have. They're really skilled in reaching people, especially those who are kind of in the margins of society. So curiosity was the biggest factor as why they want to come in blue. You see it. For those who came just want to seek knowledge about about sexual well-being. You can see that in yellow. That was quite a large proportion of people put there as their primary motive and for coming up and seeing what Shift is all about. So seeking knowledge about STIs is probably not as big as what you might think, and I think that's a factor that's coming through in a number of talks today. Even though it's a major driver for Shift initially, it's not the overwhelming desire for people to talk about Shift. They want to know just about sexual health and well-being as a whole, and not just one factor of it. And concerns about STIs and HIV worldwide is again a small proportion, and just looking for support generally with STIs, that comes in there as well. And participants were willing to talk about what's the sexual well-being. Just want to talk about just general well-being as well, with the sexual well-being as part of the overall well-being context. So I think it's important. So we don't only focus on sexual well-being alone. We talk about the other conditions that we mentioned as well, things like in the older age, things like cancer and heart conditions and so on, chronic lung problems, etc. So it's important people talk about it within the round. They want to know access to support. Okay, where can I find this? And it's really interesting to hear about the homeless one as well. That Amanda was saying that people would go and they'd bring their homeless friends, or to try and connect with them, bring them to the Shift tent or the Shift bus as well. I think it's really important to see. And just general all-around sex and sexual issues was one of the driving ones as well. But also just general want to know more about methods of protection. We think everybody knows about condoms and so on, but it turns out lots of people don't know what we think might be the basics around sexual health. So that's why Shift is incredibly important, and it's a key question. And HIV is always going to be a factor, but it's not as big as what we might have thought in those outreach groups. We've seen a number of word clouds today, but I think in terms of the ones of why they're coming, why they want to talk about Shift and what they're learning from it, it's important. I think intent comes up well. It's good. They intend to change their behaviour. They intend to change their attitudes. They intend to increase their knowledge. They intend to feel less shame and stigma. That comes up a lot. They want to increase their confidence to talk about sex. So I think that comes up a lot. And seeking professionals' help, and knowing that their friends probably don't know as much about it. They can't just talk about general family members or friends. Maybe they can't trust anyone to talk about it. They do seek professional help, and that's one people we're trying to broaden access to professionals and increase the knowledge of professionals to be able to talk to these kinds of populations. So we do find with the outreach work in the UK that we did find quite big increases in knowledge, awareness and access, and we did see some reductions in stigma. You're never going to reduce stigma completely as much as we'd like to, but we are seeing some positive effects. So it's either that or so the positive effects of what the outreach work that was done in the UK by Amanda and colleagues and so on. We're moving on to a specific one as well. And I thought it was a really interesting point made by colleagues earlier, with that there's a lot of known about men who have sex with men, and there's more support for them than there is, say, for lesbians and for transgender and all kinds of other populations. So, it's quite a big subculture as well, and it's something that we're trying to reach with Shift. And for example, Stephen, our colleagues in the NHS, which you've seen already this morning, speaking with Monique. So Stephen went to a specific sauna, which is for men who have sex with men, and that's what MSM stands for there. And so it's a very private place. It's not too well known, but these are people, and it's interesting. What Stephen talked about his own reflections and talked and trying to deliver Shift and about Shift. Again, this is an example of our harder to reach, more invisible kind of populations on the margins that not many people might know about. And Stephen was saying, like, for example, this gentleman was one of them in his late 60s. We discussed that he has been married to his wife for 38 years, but they haven't had sex for a while. It's about 5 years. And he informed me that this is affecting his mental health really, really badly, and his whole well-being is reduced. So that's when we're talking about sexual health and well-being as a whole. And he noticed that 80% of the people were over the age of 45 in these saunas as well. So it's not young men having sex with men in these saunas. It's our general demographic by and large, which is really, really, really important. And a lot of people there, when they were married, there was a lot of heterosexual people who were claiming they were married, but then they're too afraid to say that they are genuinely homosexual, or they have desires for people of the same gender, but they don't want to split up their marriage. Maybe there's just too many issues around maybe having to divorce and all the problems that might come along with that. But they desire people of their own gender. So that's why it's kind of margin. But they did actually talk to Stephen quite a lot. So some people separated, some people are married, a large portion are married, but we do have people identifying as gay and lesbian, identifying as bisexual, identifying as heterosexual, but still going and not sure just yet, just sampling that environment and see is it for them. So they found why would they talk to us? There's like they had very different reasons than just a general outreach one. They were more savvy about STIs. They were more concerned about STIs than the general outreach one population that Amanda was talking about earlier. I think it's important because they are more aware of it, and so on, and they can see it. And there seems to be some more kind of messaging in that environment about the risk of STIs. So they're talking more about seeking knowledge and seeking help, seeking professional help, but they wouldn't normally go to look for it. That's why Stephen's work there was really, really important, raising awareness of shift and knowledge of services they can access and so on. So with Stephen said there was some knowledge, awareness, and access as well. And the stigma there is an interesting one in that it didn't change in the direction that we expected. So there does seem to be some kind of shame thing there as well. They're not really sure about themselves. It's not public. For those who are married, the wives definitely don't know about it yet, and so on. So something that they're not quite ready to. But I think it's something that Shift could really help with. So with the sauna environment, I'm going to really talk about using kind of Gibbs reflective style. This is some of Stephen's own reflections from there. And it shows that it's really important to think because we can't just assume that we are so sex positive with Shift. We think everybody wants to talk about sex and everybody wants to have a happy sex life and a healthy sex life. And that's something we're really trying to promote. But when we're trying to send our workers, like with our work package 3 people, into these kind of environments, we have to train them as well to be able to cope with this kind of different environment. For example, as Stephen says, with conclusion, I do need to do some reflection on how I kind of cope with this, bounce back from this, because you see a lot of images as well, and he refers to seeing pornography pretty much wall to wall on screens and video screens in the saunas, and he said it's a sensory overload. How do you decompress from that? How do you look after yourself? So it's all about how do we have self-compare and compassion for our own shifted workers, as well as the populations that we're trying to target. He'd forgotten how different the type of environment was. He didn't expect it to take as long as it did. It did take a lot out of him. And there are times he got distracted by the images rather than focusing on presenting the shift message as well. But he did say he would become desensitized. But this might be just with this type of environment. There might be lots of other outreach work that might be quite challenging with shift. And we have to take care of our own colleagues and partners that we're training in this environment as well. So moving on to our Dutch outreach, so some really great work by Wim and Tatiana and colleagues in SOAID. So they, as they mentioned earlier, so they've done the work right here in the Schilderswijk. And so with most of the work has taken place in De Mussen, which is literally just down the road from here. And as Tatiana mentioned this morning, there's some work with the Steck Food Bank and also with the World House as well. So we sampled around 300 and just over about 350, which is really, really good for this hard-to-reach group. And as Tatiana says, mostly mothers, but there were some other groups as well. But that was, you can see by the broad range of people where they're from and the variety of countries that are represented here in the Schilderswijk, from like Morocco, from Tunisia, Suriname, and so on. So it's a really good test bed, I think, for Shift, as Wim and Tatiana outlined. So what kinds of things were they talking about? And I think there's some really important themes coming here, because I keep coming back to the sex positive thing, because we talk about it so freely and openly here with a very like-minded group of people that we just assume that everybody's going to talk about that. But not everybody in society is open, and not everyone has the same freedoms that we have. For example, they were saying that I didn't know who to turn to. They said I'd find it very difficult to talk about it with my husband. People said it wasn't culturally accepted within their Muslim religion to talk about sex or to challenge their husband, and so in certain ways as well. So there are risks that we can go home, and we have to take care of making sure that we're not putting our own kind of clients and our populations maybe in a more dangerous situation by encouraging them to maybe say and do things which might not be culturally sensitive in their particular environment. So it's just about becoming more aware and a bit more savvy and a bit more nuanced in our shift programs. But I think we're getting there. But also people said, I'm happy I could share my story because they had no one else to talk to. I think this is really important about what Wim and Tatiana have done, is that they literally the first people I've ever talked to about their sex life. So they don't have sisters to talk to, but they're afraid to talk to other people in the environment because if something could be said and passed down to family members and so on, it could have some negative consequences for them. They talked about learning about the pill and other sources, other hormonal methods that they weren't aware of as well, especially coming from different countries, that there might be more open things and more different varieties and methods that they might not have been available in the country of origin, for example. I mean, it's nice to hear say that they actually loved the subject and they learned a lot. I think that's really nice as well for us to say. So this is something that people enjoy doing and something that we should be proud of as well. They talk about things that they'd like to talk about in the future. We talk about future topics. They say, okay, this was great. What would you like to talk about in the future? They would like to talk more about contraception, learn more about that. The menopause comes up constantly. It is one of the big themes of the day. And it's true, we do come from a fairly misogynistic health kind of delivery model where women's problems haven't been given the same kind of respect that the men's problems have. And I think that's becoming more different now, and hopefully it's changing. But menopause is so important, and it's something that has been ignored, I think, to a large extent. Sex as you get older, so that's obviously what Shift is all about. They also want to know more about sex and chronic conditions, which we've started talking about in Shift, and our Shift website has a lot of information as. But also just looking after the older body. There are some things that are not particularly in our scope with Shift. They're interested in the sexuality and their children and how to cope with that. If their child, for example, wants to express as bisexual or transgender or lesbian or gay and so on, and it might not be culturally approved of in their particular, say, religion or cultural ethnicity background. That's not really within our domain, but it's something that they would like to discuss in future. So moving on now to the Shift website, which is our Shift model. It's what Munyi and Stephen talked a lot about this morning. I think it's really important. So this is where all our ideas and the needs analysis came into one place. This is our kind of a one-stop shop for all information about sexual health and well-being, where you can get access to anything you need in one place. So just looking at the analytics, so we've seen it's almost 5,000 people have accessed it so far. We just launched it a few months ago in May, but it's kind of a shell of a website around then. We're more interested to see that there's been a lot more uptake over the last few months as we've added much more content to it, and includes, and we've seen some excerpts, includes all information about sex and after chronic health conditions, but also things like menopause, perimenopause, and so on. But there's a lot more just generally about sexual health and well-being. We see certain spikes after we've launched the website, and we've seen some bigger spikes as well when we've launched those film screenings that we'll talk about that were done in the month of September as well, and also about the conference. You see there's clear spikes when we've been expressing information about the conference, putting it on our social media platforms and so on. So we are seeing a lot more uptake in views in the website. We still need to reach a lot more, but I think approaching 5,000 is a good start, but we definitely have to do more. So just looking at where they're coming from, it's the people on a sign. So it's nice that people who are seeing it aren't just told by us to see it. To say, because you're doing a work package 3, you have to look at the website, or because you're in work package 2 outreach, you have to look at the website. These are people coming themselves of their own accord who haven't been told to go there by us. So I think that's a good sign as well. You can see where they're becoming mostly some by direct referrals as well. Hopefully by people who've taken part in work package 3 trainings are now referring clients of theirs, patients of theirs to look at it as well. I think it's really useful. But there's a lot of people coming from the organic searches. I think that's really good to know that the Shift name, the Shift brand is getting out there. Just look in terms of briefly looking at the analytics and the top views. Obviously, the homepage is the most viewed with over 6,000 so far. And what we're seeing as well, are people spending long on the website? It doesn't sound long when you say 50 seconds on a certain page and so on, but that's very typical of most websites. The ones that people spend most time are on menopause again, and that will come up time and time again. It's a really key issue. So people are spending about a minute on menopause, just over that, and also when sex becomes painful. So people in our target age group, there was sex has become a bit older, painful and older. And Sharon mentioned earlier about things like vaginal dryness as well, and also for men with certain conditions around erectile dysfunctions, etc. as well. In terms of the professionals who are using, we've had 456 views. We hope to raise this a lot more, but that's pretty good from the population. It shows us at least as well that that's only about 1/10 of our overall views. So 9/10 of our views are from our target population, which is also, I think, is a really healthy sign for Shift. A lot of those professionals would have come there through the work package 3 trainings and curiosity as well. Just also, how are people accessing Shift? How are they seeing the Shift model? When we were doing our needs analysis in those early days, for example, at Metro, when I remember there was a discussion, we thought that most of them would reach it through tablets. It's the idea that older people will like their iPads or tablets a bit more, and they're nice and big. But actually, most of our age group are targeting by their smartphone. So over 60% is by phone, and only just under 10%, around 9.3, access by those kind of tablets and phones. So just because we make assumptions about our group, the data often tells us something different. So about just under a third are accessing it through laptops and desktops, but the majority are still accessing it by their mobile phone. So we do have a lot of people that's including people over 65, so it's not just people in the 45 to 65 group, that's people over 65 as well. So who's accessing Shift? Who's getting onto the website? Where are they from? And we'd hope, obviously, we want it to be a European-wide model. So we're saying the majority is by far, so far, is almost 4,000 have accessed it in the UK, and 147 in Belgium. But it's been reaching across the Atlantic. It's reaching the United States as well. So we've almost 200 people that have accessed it in the US. It shows the reach of people in Shift as well. In the Netherlands, it's 130. We hope to have more in Belgium and Netherlands over time as word gets out. We originally had a French partner as well at the beginning of the project, so that's something we'd hope to get some reach, especially within the northern French region, which is originally part of 2Cs. In terms of the breakdown, we're really pleased with the actual gender breakdown, because when we thought that doing this project initially, we thought that we'd have a very high female kind of bias in terms of our percentages and demographics. But it's an almost 50-50 split, or as close as you're going to get with these kinds of things. And we can see, so it's 52% female and just over 47% male. So that's a really good split, really good representation. We also see with our age groups as well that we are reaching those. You see the biggest portions are 35 to 44, just under it. But we have large portions of people 45 to 54, 54 to 64, and so on, 65 plus. So we are getting those populations. We're always going to get people under 45 who are curious about sexual health as well, which is why they'll go there. But we are reaching our target demographic, I think. I'm moving on now to what we call a Think Aloud study. So we just want to see, could people use the website? Just because we think it's easy, because we know what it is. We put the content there, and we know immediately where to find what section about sex after heart attacks or the menopause. We'd know where to find it. But would somebody else who's never used the website be able to find it easily? We want it to be very user-friendly. We just can't assume that. So Think Aloud is a version of protocol analysis. It's just asking people to speak out loud while they're using the website and seeing can they answer some predetermined questions that we have about, can you find certain the Shift videos, can you find information about menopause and so on, and then they have to speak out loud as they're doing it, and then we recorded that, and then we recorded timings and so on of the ability to find it. So it's a really good way of measuring the usability of your website, and just generally speaking, the Shift model as a whole. So it's a useful qualitative analysis. And we find the participants access the website and just vocalize their thoughts and their actions as they're going on, and we re-record it as it happens. So it measures their subjective user experience of the website, and just because we might think it's great, we have to find out from our users and our clients and our patients, do they actually think it's good? So you generally 5 to 9 is considered ideal for Think Aloud, because it's quite involved. There's a lot of transcribing, there's a lot of questions, a lot of recording involved. So for Work Package 1, we met that with our three men and 3 women, including some trans men and trans women as well. So with the relationship status, there were some were married, so the majority, whereas 4 were married. 1 was in a partnership and 1 was single. So it's a good representation, I think, as well. And a sexual activity as well. 3 of them said they're currently active. 2 were active within the last 3 months and so on. So it matches what we think people are doing. In the Work Package 2, it's harder to reach them, and it's harder for them to use the technology. And indeed, that's one of the basis also of one of our Shift videos, our Shift films about one of our migrants who finds it difficult to use computers, and he's at computer class, and there's other issues as well. But it kind of taps into that. For our Work Package 2 participants found it more difficult to use the website, but that's because they're hard to reach. They have less experience with technology. A lot of them are living in very difficult, deprived conditions. Some of them don't have homes of their own and so on. So naturally, they wouldn't be able to navigate the website as well, as readily as the Work Package 1 participants. And we found that, for example, one Work Package 2 participant did not successfully complete what we thought were relatively simple tasks of finding information, finding the videos and so on. Another Work Package 2 participant did not successfully complete one task, but generally tried too hard and ended up skipping a couple of tasks. So that matches our hard to reach group. So our hard to reach are genuinely hard to reach, and so it kind of fits into that. But generally speaking, we're pleased with the data we got. When we asked people, what was your first impression of it? And it's very good, generally speaking, overall, and that's across with the yellow is Work Package 1, the blue is Work Package 2, and the pink is overall views. So they're really, really strong data for the credibility of the information that there. How believable is our information? Like, would you trust us? And is it easy to navigate? Is it easy to come back to the home page and so on? And so people found it very easy to use it and to go back to the home page when they need it. And also they found it very easy to find information, for example, on the menopause, and that's really positive for us. At least it's there. We know it's there, but other people can find it, generally speaking, readily. Apart, we have to take into account our population. For Work Package 2, it was that bit more challenging. And what we see as well, look, we always go back to our four key words for shift: in knowledge, access, awareness, and stigma. So what we find, did these change over time, and after going to the website? And we found it did. So people said, they reported that their knowledge increased. So if it's going in that direction, then it's more than before. And if it's going in that direction to the left, it's less than before. So the only thing that was less than before is stigma, and that's a good sign. So stigma it's reducing. It's not going down to bottom. So you can see it isn't going to bottom. It's really hard to shift stigma, but at least it's going in the right direction. We're seeing some really positive results, especially for awareness. If you see for awareness for Work Package 2, that's a huge increase in the dial for awareness. People in Work Package 2 were becoming aware of sexual health needs and conditions and services, things that they didn't know about. So that's why shift is really, really important. So we're seeing some really, really positive signs, I think. And it's leading, again, I'll go through this quickly because it's been mentioned so often today, knowledge, awareness, and access, and stigma. So the one thing about stigma, I think they liked the diversity in images as well. That was on the website. That wasn't just white couple who are in their 50s, a typical image that you might see. That there are people of different ethnicities, people of different sexual orientations, people of different skin color, and so on. So they were pleased to see that as well. And they did suggest some extra sources as well, like maybe some information on ageism, which came up with, which I thought was really, really clear in Dr. Hinchcliffe's talk earlier on, but important. Maybe we can include extra information, that maybe we can include more information on culture to help reduce stigma as well. And I think it's important because we might think of it as the end product. The Shift website will always be developed. I think it can be developed even more. It can develop even more personality, I think as well. But I think generally speaking, the fact that it increased their knowledge, awareness, and access, and the links were credible, that they believed that this was a good source, and they believed that was a way to get into NHS services or services in Belgium and the Netherlands. For the usability as well, just at the bottom, we said that it's intuitive, it's really good, it's easy navigation, and they like the headers. And the videos this was the key one. Like, we think the videos are so important to Shift that we think they should be top ready. We think they're easy to find, but they actually found them difficult to find. So maybe that's something we have to think about when we're revising and developing the website, that we make those videos upfront and clearly accessible, because they are so good, and they provide the really key information visually for people. So, but they found it more difficult to find than what we thought they were. So Work Package 3, which was outlined in great detail by Kate and Luca just a few moments ago. So just looking at these training packages, who took part in them. So we've had about 536. There might be some more, but it's about that. That's a lot. We're getting closer to our 700 target, so we're doing extremely well. So the people who've taken part, the HCP stands for Healthcare Professional, WW stands for the wider workforce, and students, just as Luca mentioned, students quite a few times. And we've got some questions from the online audience, where students as well. That's really, really positive to see. So that's the three kind of major groups that we're seeing in Work Package 3 trainings. And so 109 completed Assess and Communicate, and 141 healthcare professionals completed Start to Shift. And for students, it was 77 completed Start to Shift. 77 completed Assess and Communicate, and 33 completed Start to Shift. There are some differing figures. For some modules were taken more than others. And as Luke was saying, that the Start to Shift is easy to take because it's asynchronous. You can do it on your own, in your own time. Whereas the other three modules were delivered by professionals, whether in person or in webinar type form. But that's more obviously challenging and resource intensive. But sorry, the overall total, when you add it all up, is about 682. So that's really, really close to our 700 target. So just looking at the completions, we see that Start to Shift has the most, because that's the first one people generally did. And Assess and Communicate was really popular as well. It looks as if Embrace Difference wasn't that popular. It was just actually, it was run less. There was certain issues with the people who delivering those particular modules on certain times, but it's not that it's unpopular, it just wasn't run as often as the others. But we're seeing with who's taken part in it, and we can see with the healthcare professionals in blue, they are the largest portion for the reduced risk and for the embracing the difference. But it's a pretty even split for the Start to Shift as well, between the kind of students and the wider workforce versus the healthcare professionals. But we're pleased that we're accessing the broad workforce. With students, there's been less of them have taken the reduced risk, so it's something that appeals more to health professionals about reducing risk and how to communicate and how to assess them in the first place. So just going to give a quick summary of our participants. So there wasn't any participants in this from the Netherlands. It was just from the UK and Belgium. And so what we have from those who enrolled and completion rates. So it's not 100%. We'd ideally like people who enrolled to complete all modules. But the completion rates probably don't look as strong here. But there is people are generally doing most of them. It just means that people maybe not doing all 4 modules. But generally speaking, if they do start a module, that they will finish it. So they've got, like, it did increase their, you can see some of the figures there, it did increase their awareness, it did increase their reflections of barriers to their communications. It made them think about different referral options, who they could refer on to if they didn't feel they had the expertise to deal with that specific condition or request or need and so on. So I think there's been really, really positive findings, and also that feeds naturally into what Luca and Katie were saying with their own feedback that they've got from the people taking part in work practice retraining. So I think that's been a really big success story of Shift. So who's taken part? So there's been 160 have taken part in the UK, and 41 have taken part in Belgium. And these are just breakdown figures. I won't spend long, but it gives you a figure of who's taken part. We just didn't have any Dutch participants in that particular element of Shift. So just in terms of has it worked? Like Luke and Kate said some really nice qualitative stuff. Okay, that's fantastic. But is there any data to show that it does work? And what we're seeing that it does seem to work. For example, if you take Start to Shift module, we're seeing large increases in knowledge from blue is the baseline, and the orange bar is after the training. So there's just quite large increases. There's also increases in their confidence in speaking to these kinds of clients and patients, and just the range of issues that they'll come to, and just these people who are over age of 45. Also, does it help them with their professionalism? It does help with their professional facilitation of these sessions, and it does help with decision making. But I think it was a good point as well, because you both mentioned in the previous session that these are people who, and also some of the questions mentioned as well, these are people already interested in sex, and that's one of the reasons why they've signed up to take part in these modules, and that's why the blue levels are not lower. I'd say once we start to roll out these kind of trainings to a much wider range of professionals, the initial baseline levels of confidence and knowledge and professional awareness will be a lot lower, because they won't have had the same experience, maybe interest in sex, but they want to learn more about it, and then you will find even bigger increases. But we're seeing really positive effects of the trainings carried out by our work practice tree professionals. So looking at the knowledge conversation as well, this is a really positive increase, because that's a difficult one. This is an assessing motivation. We're seeing big increases in communication. We're seeing very similar increases in their abilities to deal with barriers and understand barriers, bring up these barriers in conversation, and be able to facilitate these particular sessions and talk about sex and sexual needs and well-being in these populations. In Embrace Difference, I said, even though it's been the least completed module so far, but we're still seeing the positive differences in our knowledge, confidence as well, and talking about differences in race, in ethnicity, in gender and sexual orientations and so on, and needs and awareness of the different types of people that will come to them, and also how to communicate to these. We'll see very similar figures as well. We're reducing risk. So we're seeing positive things that they know how to talk about risk and how to reduce risk with their populations, but also their interpersonal skills in reducing risk. I think that's a really nice effect there on the last bar as well. But also just general case of the kind of knowledge and about risk reduction. We're seeing that these modules are really well tailored. There's a lot of really detailed information in there. And even Monique mentioned just as well that even as a health professional like her with so many years experience as a doctor in the field, she still learns something from the work practice training. So there's something there for everyone to increase our skill level, increase our ability, increase our professionalism, and increase our knowledge. So in terms of the overall satisfaction, CC does very, very strongly agree. So it's the dark green is strongly agree, and the paler colour is agree. So by and large, and everyone really, really liked. There's only a tiny proportion where weren't satisfied with the program. So by and large, I think that has been a success. And these are higher ratings than you'd nearly get for any kind of training packages. Certainly in lots of other areas I've worked in psychology, you don't normally get figures as positive as that. So moving on now to our Shift film screenings, which is really, I think this is another one of our successes. These were really, really nice nights. So I was at one of them in Eastbourne, in East Sussex, and it was really positive. And there's one also in Kent as well, in Ashford. So these were nights where we presented our 6 separate individual Shift films that we have tailored and written the scripts and recorded and put online, and they are in English and Dutch across themes such as marital dissatisfaction, where the one partner wants sexual activity and the other person doesn't, menopause, people who don't know much about HIV and are scared of the risks of going out with somebody or dating somebody who has HIV. So we cover some really pertinent issues, I think, in those six videos. So at these film screenings, we asked people to rate the films, to rank them, to talk about the issues, which were their favorite, which ones they thought kind of tapped into issues that they thought were relevant for them, and which videos mightn't have worked, just because, again, like we might be really proud of the videos, but they might go flat for certain groups. They think that it doesn't communicate to them, it doesn't talk to them. But thankfully, they were all really well rated. But generally, so we put them in rankings. So Chris and Marlene's ranking was first by just under fifth of participants. That was about intimacy in relation. I think that's an important one that we kind of that we really talk about, not just sexually transmitted infections, but emotional intimacy and physical intimacy is so important. But you can also see that it's ranked number first by 22%, but it's also ranked last by a third of participants. So there is some variability. It is kind of like a Marmite thing that people like it or they don't, for some of them. And we see with the last one with Karen, for example, that's quite across the board. It's her new relationship that she's trying to enter into, and knowledge about sexually transmitted infections. So she's ranked first by 11% of participants and ranked last by 16%. So there is some good variability over there. But so the most popular one seems to be the Chris and Marlene at 22% in terms of the first ranking, and the least. But it's also the least popular. So it's a bit of a contradiction. It's the most popular, but also the least popular across people. So they either liked it or didn't like it. So you can see by the 0% for the second and third ranking, just didn't fit in there. For Marco was quite consistent across the board. That was the migrant I was talking about earlier with his own sexually transmitted infection problems, and he was at the computer classes. I think that one that did appeal to people when I was talking to them afterwards as well. Myra and Lucas, the relationship is quite popular, you can see, but it's quite consistent across the rankings from 1 till 6. But it's just useful information to show what people think of them in general. And a lot of people thought that the films were thought-provoking, and in their favourite film, they felt moved by it. So a good proportion thought about. So the dark green is very strong. Strongly agree, and the pale green is agree. So by far the largest proportion agree or strongly agree that they thought the films were useful. They were informative, and it helped them to change the way they think about sexual health and so on. So they thought that there's just seem to work. And these videos are good messages. I think they do get them across in the right ways. They also talked about the least favorite film and whether it changed their views about sex, or whether it moved them in any way emotionally as well, and whether it was thought-provoking. So we have some really good detailed information on the effectiveness of each of these 6 videos or films. Looking at some of the qualitative feedback as well, I think it's also so the positive ones. So they thought it would work really well on social media. Some people said it could work even on TikTok. Again, we have to think of ourselves: would TikTok be relevant to our target sample of over the age of 45? It might be. There's been lots of times in Shift where our assumptions have been proved to be wrong, and the actual data is counterintuitive. There's something that we could think about, but there's something about the length of them and the accessibility of them. I think that people think that can be used across multiple platforms. They think it's so important. People were really nice. People said that these videos and films are so important. Just keep on doing what we do in Shift, developing these. And they said it's just that it was very great, and they're very thought-provoking as well. I think that people said they're much more thought-provoking than your typical public health message. The short videos that you see in clinics and that you might see on TV in short ads, there's much more depth to these Shift films. They're tapping into just various needs and not just the one issue that the story seems to be about. There's a lot more involved. And they said there's excellent films, that they weren't too long as well. They were easy to engage with. They're easy to understand. And people said it was great development, and they loved the films as well. In terms of things that we could do, maybe you could add further information to the films, maybe improve them a bit. Maybe you could cover more topics. Obviously, we were limited by budget and so on, and it's very challenging and resource intensive to film these and record them and so on. But we are seeing some really good things. They're saying, if you could do more of these videos, they're great. So it's not a negative comment, it's actually a positive one, saying, can you do even more? These are working really well. Could you add further information? Some people thought that maybe the one about the couple and the relationship and the lack of intimacy and so on might have been a bit too complex for just one short film, and maybe perhaps that one could have been expanded a bit to explain what was really going on. But by and large, it's really positive feedback. I just want to say thank you. I'm just the public face of a lot of people's work. So this evaluation is actually the entire project. So everybody has fed into it, and there's been Trojan work done behind the scenes, and very much led by people I have to thank. Victoria Giacomelli. Everybody knows as Tora. Thank to Izzy Ball as our two main research assistants who are constantly working on the project. I have to thank Ruth Larry as our kind of lead research consultant who has provided invaluable advice throughout the entire project, and also back in Chichester with Professor Anthony Napier and Dr. Marty Banerjee, who've been research advisors on many aspects of the project and done really sterling work, and former colleagues Susan Churchill and Tess Hartland, who were involved in the project at the beginning and did some great work as well with evaluation. And also we've had student volunteers at Chichester, Riz and Ashton, who've done some great work with transcribing interviews and think aloud studies as well. So there's a lot of people, there's a lot of work going involved, but it's also the entire project partners and all the work that you've done today. And thanks very much. Okay. Any questions? Yeah? Yeah? Okay. Yeah, Heilige.
Not really a question, but more about the training packages.
Yeah.
So it's clear that Embrace Difference and Reduce Risk reached less professionals. As you said, it was about some boundaries, but also we noticed that a lot of the shift partners started with the Assess and Communicate first, because that one was the first that was originally drafted, or the first one to be ready and to put out there. And then once people or trainers got comfortable with giving the training, I feel they were more positive and wanted to give the training again, and then that's why we did less training on the other stuff, I think. What was very interesting about the Reduce Risk is that the professionals felt that also their professional or their interpersonal skills were better after. Is that what I saw?
Yeah.
So coming back to the fact that someone asked about knowledge and do you need a lot of knowledge about sexual health, that's a good referral to the fact that we try to put in a lot of aspects on more reflective exercises and assignments to think about your own situation, your own professional environment, and not as much as what should you know about this illness or that sexual dysfunction, or we do talk about those things in the trainings, but it's more the awareness and how to talk about risk and risk assessment. So.
Yeah, I think it's really useful because that came across in especially in the work package 2 interviews that we did at the beginning of that study, and that a lot of people mentioned that the GPs, but the healthcare professionals generally didn't know how to talk to them about it, and they didn't want to talk to them, and they felt that they were cold and dismissive. So the fact that you were seeing that increase in interpersonal skills from the healthcare professionals is incredibly positive, and that's directly getting what we found a couple of years ago. So I think that's really, really useful. Thanks, Olivia. Any questions? Money?
Can I throw?
Yeah, good catch.
And I can catch.
Yeah.
Ian and Chichester's team and Ruth, thank you so much for this evaluation, giving that strength to the SHIFT project, giving that kind of evidence to say that what we're doing is making a difference. And as you say, knowledge, awareness, access and stigma reducing and improving in the right orders is perfect. Question back to you. If we had more time, what alternative evaluation would you like to see, or what additional evaluation would you like to see to help make SHIFT even more robust and more kind of widely disseminated?
I think if we could go, and a really good question, I think if we could go back to those in the original kind of application for SHIFT, and I think it's just a pity, and we do have to accept that COVID is just kind of I've seen over the last few months, it's almost like a collective amnesia about what happened with COVID, and things probably weren't as bad as we were, but everything literally was shut down, and you were pretty much working 24/7 on COVID, as well as lots of others. But I'd love to have got the chance to evaluate the pilot model over 12 months, as originally said. Well, for some models it was 18 months, but from other packages it was 12 months. I'd love to have been given a chance to properly evaluate the pilot and then tweak and adapt and evolve our model on the basis of that, and I've done it since. And I'd like to have seen more work package 2 as well. I think that's something that it's so different, but it was very clear again when Amanda presented, and she presented a list of what she considers work package 2. It's huge. It's absolutely enormous, and they're really different populations. So we kind of assume work package 2 is one population, but it's so diverse, and by the nature, they lived up to the name of being hard to reach. So I'd like to see a lot more of that. I'd also like to see us evaluating with the model and the website. I'd like to see that as having a bit more personality as well. I think that's coming through in some of the evaluation. The information is great, but maybe more dynamic, more interactive, more obviously shifts that's different, say, to an NHS information website, just something a little bit more to targeted populations. But I think, and also just like to do maybe some more statistical analysis of some of the surveys. If we designed the surveys, if we had time to design the surveys in a slightly different way, and we had more access participants, that we could do more statistical analysis, and we could be more certain of changes over time. But we've seen really positive changes with what we presented so far, I think, anyway.
Yeah, no, definitely. I think, as you say, if we can see shift continually evolving, and those that are in the audience, both in person and online, spreading the word more, keeping things moving, content can be added to the website, trainings will continue. All of this will keep going as long as we keep that momentum. Thank you.
Thank you. Don't think there's anything yet on the live chat. Any further questions? Oh, okay. Yeah, I can say that. Yeah. Yeah.
Not mic'd. Okay, we're very, very close to the end of our day, and thank you so much, Dr. Tindalli, for a great presentation. Yeah, you can clap. I can see you guys are ready to clap.
Okay,
Let's clap.
Exactly.
Yeah, it's so interesting to see it all come together like that.
Yeah.
As the very, very final part of our day, we have, when he's looking very keen, we've got a panel, a very quick little panel discussion. So I'll invite Dr. Ruth Lowry and Sally. There, you're there, yeah, Sally. Sorry, I didn't know where you were. To come up and join us. Do you guys want chairs, or should we? Are you okay? Yeah, maybe let's grab some chairs, will we? Thanks. There we go. And maybe one more.
I'll take. No, first. Yeah,
there's one for you.
Okay, thanks.
One for you. And maybe one more.
I'm gonna get one. You can't take it on.
Yeah, maybe. Thanks. I don't want to be the last man standing.
Yeah, it's the end of the day.
I know, the end of the day. I'm tired. Okay, so the purpose, we really only have, I think, about 20 minutes left. Quick time check. Is that right? How much? 20 minutes. So I think the idea is if there's any kind of urgent or burning questions that anybody wants to ask the panelists, and then for the panelists to just give some final thoughts on, what are the key learnings, the key take-home messages, the things that we really want to reinforce at the end of the day. Should we do questions first or thoughts first? Questions first? Happy with that? Any burning questions? Ross? We probably have time for 2.
Just one then, I promise. How is this project sustained when the formal project comes to an end?
Good question.
Interesting, was one of my thoughts as well. I don't know, my thought was, I have the feeling that we just started and we're really on the roll now, so how are we going to sustain this? And I think I can only answer this part, at least for the Netherlands. How we're going to do it on European level, I think the group maybe can answer that. But I think for us, so looking to all the presentations today, I learned that we're actually in the Netherlands already quite strong in reaching certain populations, like the LGBTI, sex workers, etc. But we do have a gap in migrants and heterosexual people that are above 45. And for us, we work on a national level, so we do a lot of our own programming, and we do work a lot with community-based projects, but not with this neighborhood approach. So I was really, really enthusiastic about that, and this is something which is really new for us, that we really work with partners that really locally are established to search for the hard-to-reach or the groups we are not reaching. So for me, the wish in the Netherlands is that that will somehow continue. And we were already talking today about that we had some fun. So we were already, it's living in our minds. So yes. And the other thing is, so we do have national programming that just continues. And I think we should adapt some of the knowledge that we learned here. For example, we deliver all the STIs and HIV programming for people in the Netherlands. But from my perspective, we've never really checked if this information is suitable for the older generations as well. So for me, this would be the first step, and we can just really do that because we have all these programs.
Yeah, I think it's important to sort of stress that we have built in a 5-year plan. So the training packages that have been prepared, they will continue for another 5 years. And the website is, there's funding to support it for 5 years. So that's a minimum commitment that's been financed through the funding that we've already got. I think the next stage is then for each of the partner organisations and their observer partners, as they're called in the application, to really harness the evidence that's been gathered, the good progress that's been made so far, and look at how they redeploy the funds that they have otherwise. Would that be the polite way of putting it?
I think that's a very polite way of putting it. Ian?
Yeah, and I think it's a good question, but I think we've also got something called our community assets list. So every partner organization has a large group or large kind of network that we're involved with or connected with in some way, and that can be charities, that can be health care professionals, can be just a wider workforce, county councils, and so on. So I think it's just up to each partner to keep communicating about Shift and about their trainings and about the website, and offering opportunities to come and talk about Shift and to train people up in the model over time. But as Ruth said, is already built, that the 5-year plan is currently already built in anyway.
So the other element is that Shift didn't happen in a vacuum. So it wasn't a case that people were all plucked together. Shift actually happened from a previous existing project that Monier and others were involved with. So Shift is also the accumulation of the learned knowledge from that project, and whether Shift partners or a combination of them and other partners come together for another funding project to extend the work, that's also a possibility.
Yeah, absolutely. I think that if we harness the passion that we all clearly have, as well as the amazing evidence that we've gained, there's definitely grounds for future funding if we can find it. I'm only chairing the panel, though. I'm not supposed to be answering the questions. I just can't resist. I saw somebody else had a hand, and I felt like it was over in that direction. But nobody's making a... No? Yeah, Luca?
I was thinking in terms of sustainability, and then especially for the training. So a lot of the partners are educational programs as well, and that's actually starting at the base. So before they start working in practice, we already teach them about sexual health. So it won't be about raising awareness. They will be aware professionals and go into the field like that, and maybe it rubs off on the other professionals or older professionals who didn't have the chance to do this amazing Shift training or something.
Yeah, I mean, for example, I have a doctorate in clinical psychology student who's working with me, and it's about trying to understand the training or lack of training within that profession's root way, and just the pervasiveness of sexual health and well-being issues that crop up in clinical psychology practice, and how whenever they go into practice, whether they're supported or not, and how they gain more knowledge. So I think just by having educational partners like yourselves and Kate and Odyssey and ourselves involved in the project, it causes us to sort of reflect on our own professions. So we're both psychologists. We train health psychologists, clinical psychologists. I train sport and exercise psychologists. So you have a whole, hopefully, plethora of graduates who might benefit from that knowledge of the project.
I agree.
Great, and I think we probably have time for one more question, maybe two. And we've got a really great one online from Emma Jones. So the question is long, and I'll read it slowly. How about accreditation in terms of training as an incentive for engaging and further developing this area of professional expertise with proper recognition for this knowledge and skill set?
That topic.
Yeah, that old chestnut.
we did have a rather lengthy discussion about this. Was it at Metro a couple of years ago?
Yeah, it was a while ago.
So within the planning of the model, we did look at this very aspect. I think the difficulty that we came up against was which body would it be accredited through? So would it be through an international organisation? Would it be part of, so for example, within the UK, we have Skills Active and different CPD accrediting bodies that are not specific to a professional organisation. So we didn't manage to square that circle in the time of the project. So we moved forward in an informal way, but I think there is an opportunity, whether it's one of the academic partners that take it on board, or whether we can talk to an international society or body to do that.
Yeah, and I think also maybe on national level, because I think for us, all the trainings that we do through SOA AIDS Nederland, they normally get accredited. So I don't think it will be quite a big step for us to get it accredited in the Netherlands, because we have that line already. But maybe we should then see for each country separate.
Yeah, I do think you need some kind of body, like Ruth was saying, that especially because there's so many ethical concerns potentially around it, as it's such a sensitive area as well, because we can't assume, like for example, our GPs and nurses will be bound by their ethical bodies, but if we're doing the wider workforce, we don't know whether they've had ethical training and so on, if they're working for, say, for a charity or just volunteering, so we can't assume that everybody has the same background. So I think you would need a wider body who's willing to, it's a huge body of work to be able to take that on and make sure everyone has ethics training before they even take shift training, I think, just to protect shift as well, and to protect our clients and our patients who are undertaking and who will be exposed to shift on the basis of our professionals who've been trained in it.
Really interesting points, and yes, I do remember this discussion from a few years ago. It was definitely a big nut that we never quite cracked. This is the very last question, and then we have to wrap up, and then we have a bit of a surprise at the end, a surprise 5 minutes that are required. So the last question, and then we'll hear your final thoughts as well. This is from Kez Spellman again, who I believe asked a question earlier, so thank you for your engagement, Kez. Is there an opportunity for sexual health providers outside of the partnership to link with SHIFT? Could this support how the work is sustained? I think resoundingly yes.
Yeah.
Do get in contact with us, either directly via our organizations or on the website. Yeah, we're happy with that. We would love to.
Yeah, I'll just say to Kez, I'll speak to you next week. So I'm already in touch with him. But yes, so Kez is from Provide in Essex. So they're one of the partner organisations that's been identified through the network.
See, and here we talk about sustainability. We've come full circle. That's brilliant. Okay, well, Ruth, we'll talk to you next week, Kez.
Honestly.
Honestly, you will. All right, so that brings us up to the very final question, which is just that we've invited these three lovely colleagues up to give their final thoughts. And I just realized that we actually haven't introduced Sally or Ruth. So maybe introduce yourselves and then give your final thoughts.
So I'm Sally. I'm the team lead of the key population team at SOA AIDS Nederland. So I've not been involved in this project, but I've seen it a little bit from the side. So for me today was, quite mind-blowing. I thought, wow, this is actually quite a big project, because it looked always really small among all the things we do, and I was impressed today. So congratulations all for that. So my take-home message, I already mentioned it, is the neighborhood-centered approach, which is new for us, and we really want to take that forward. I was also very interested in this environmental structure to use that for behavioral change, and I do think that I see two opportunities in the Netherlands, or maybe with other countries, to really do an academic research on that also. So what are then all these environmental counterblocks, for example, migrants in the Netherlands, if we want to reach them? So I was interested in that. And then what I realized, we as an organization are very sex positive in our approach, very explicit. We're really open in our communication. And today I realized, but for some of the groups that we are actually targeting now, this approach is not the way forward. So also here, I think like working with the MUSO or working with other groups to have this more holistic, integrated approach coming in to a different route and then discuss sexual health is the way forward for some groups. Yeah, so these are my points for today.
Wonderful. Thank you, Sally. Over to you, Ruth. And don't forget to introduce yourself, sorry.
So my name's Ruth Laurie. I'm from the University of Essex, but I was originally at the University of Chichester, so I was involved in the project from the application stage. So when I left Chichester, Ian very kindly stepped into the breach and took over the day-to-day supervision and the evaluation. So I suppose for myself, it's been really interesting. I've been involved in another European project, which is with DeMussen literally down the street. And what's been really interesting is seeing just the parallels between the two projects. So again, it was about embracing the assets in the community. So rather than thinking these are, pockets of deprivation, we have this academic language which is around people who are in need of education, knowledge, and resources, assuming that they don't have any strengths to draw on, which I think is a great misrepresentation of them. And I think through this project in particular, we've seen that if we understand and work with the community, we can help them to really embrace what they need to do to change themselves. And if they take ownership of it, then it's more likely to stick, essentially, in terms of change.
I agree. Thank you. And last but not least, Ian.
Yeah, thanks. No, I think one of the biggest learnings from this is I think there's too much emphasis in society on individual intelligence. I think intelligence is collective. And I think we see this hugely in this particular project is the knowledge coming from so many different backgrounds, from public health professionals working in county councils, from doctors working in sexual health clinics, from people working in charities like Amanda. That brings all that knowledge together. No one person can have all of that. And it's all that knowledge and us working together, talking and discussing and debating and refining our ideas, and importantly, listening to the actual clients. And we're trying to reach ourselves, the population, trying to reach through those interviews and through those surveys. And that has really shaped it together. And it shows that working together is still the best. When society tries to split us apart, we work better together. And I think this project has been a real success, despite the hardships of a pandemic. Everyone shows that we're adaptable and flexible, and that to hold some of our initial ideas lightly and to change it as we go along, because lots of things have changed in the project. But I think we just really have to emphasize that the knowledge and the intelligence is contained in the collective, in the group together, rather than any in one individual. And I think Shift will evolve going forward as we gain even more information. But I think from the surveys, from the interviews and all our interactions, this is a real need. Shift is needed. And I think this has a real positive impact on society once we roll it out even further.
Wonderful. I think those are powerful final thoughts. I was reminded yesterday, Mani and I were briefly interviewed, and the first thing Mani said was, Shift is important. And I think that's what we're all saying, is how important it is, and the work that really evidences itself. And hopefully all of you who are joining us for the first time or learning about Shift for the first time agree and take it forward. So thank you all for attending today. That wraps up our formal section of the day. We have a rather informal but very important job to attend to. Sally is just going to go and do something. But I would suggest that our lovely Wim, who's been hiding at the back, whose official last day of work it is ever, not on holiday, not for the weekend, but ever, 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 I would suggest that Wim comes up. And I'm going to pass the microphone over to you.
I have
I don't need to. She's got her own microphone. So I'm going to turn this off.
Yeah.
So, Wim needs to be on stage. This is Wim. He has been working in the HIV/AIDS, HCI communities, epidemic, for 35 years, and today is officially his last day. So we have a big bouquet of flowers, which disappeared, but they will come. And for me personally, because Wim is of course in my team, and we're still gonna celebrate our goodbyes, but yeah, there's a couple of people in the Netherlands that made a big change during the period from the 80s, and Wim is really, really one of them. So I really want to give him a big applause.
Thank you. Very touching.
And I think...
Well, Telly, that's very touching. And this was a great last day, and thank you all for joining me this last day. It was a great way of saying goodbye to a 35-year, can I call it a career? But at least I worked 35 years in this field, and it has been great. And what I had been saying all these 35 years until, well, maybe a couple of months ago, that I had the best job in the world. It was splendid and touching and interesting and essential and such. And well, great. Thank you.
Yeah.
Thank you very much.
Yeah, thank you on behalf of a lot of people.
Thank you.
I think the people in the room are done, but I've been told to come up and say a formal goodbye and thank you to the people online. So thank you so much to the people in the room for joining us today, especially those of you who have traveled. Thank you again to our amazing comms team from Metro and our amazing AV team who have made everything possible from the back. I was going to say from the back end, but should I maybe not say that in a sexual health conference? And thank you to all of my lovely colleagues at Shift. It has been an absolute pleasure working with you all. Tony, stop laughing in the front of the audience. It wasn't that funny. So that's it. The day is finished. If you have any questions, comments, burning questions, do get in touch with us. We love to hear from you, and please carry the Shift message forward.